Welcome to the IPC Revision Work Group, to the people in the room, to the people on the webinar. Glad you're here today to work with us some more. The third meeting that we've had now in working on revising the IPC. We're going to take some housekeeping items right at the top of the agenda here and just make sure that everybody's clear about what's going to happen today, and we'll review the agenda together. So for starters, for all of you who are joining us via the webinar, we're glad you're here, and we also are glad you're here to work. So definitely want to make sure that you know that we're going to have you unmuted. We need you to keep your phones on mute because we want you to be able to join in the conversation verbally if you can. If you can't, then don't panic. Send us some notes if you think that you just need some help in getting online, and or if you are unable to speak to us verbally, definitely want you to send us messages via your text box, and we will we'll stop and respond to those as we get them. So so glad you're joining us, and definitely want to hear from you today. So make us stop and hear you, okay? To the people in the room, welcome. And some of you were here for this morning's meetings, because this is an all-day adventure for some of us, with Quality Work Group in the morning, IPC in the afternoon, and a number of you are carryovers from the morning meeting. So thank you again. And I think what we're going to do really quickly is we're going to go around the room and just say who we are and what organization we're from, and then we'll do a roll call for the people on the phone too, so everybody knows who's participating in this effort. We can start to my left.
I'm Chris Christie. I'm with Adult Healthcare in Merced.
And make sure you speak up.
I'm Eden Rosales with the Department of Aging CBS program.
Long-Term Care Division in the Department of Healthcare Services.
Amanda Sillers with Total Adult Healthcare Solutions.
Selena Escobar, Manager of Public Programs.
James Kawakami, Manager for CBS LA Care.
Gretchen Brickson, Senior Director, MLTSS LA Care.
Lydia Missilides, California Association for Adult Day Services.
Selena Regalia with Napa Valley Hospice and Adult Day Services.
Myers Perky, Health Center.
Ms. Raven from Forever Young in Chatsworth.
Liz Machado from Dayal Adult Day Healthcare Center in Raleigh and El Centro.
And Jill Sparrow from California Department of Aging, CBS. All right, that's great. So what we're going to do really quickly, and again, I'm going to encourage the people who are on the webinar to make sure that you put your phones on mute when you're not speaking, but then we'll have you unmuted on our end to the degree it's possible, because sometimes there's background noise, but we're going to try to keep the mics open so that you can join in the conversation. So what we'll do real quick is do a roll call. If Adam Smith from our shop will go ahead and or Kelly is joining him back there, will give us a roll call of who we see online, and if you can verbally jump in and say, yay, I'm here, that would be great. If you can't, we'll just know that you're hanging out there, and then we'll expect to hear from you in the text box.
All right, we have Amanda Pacina.
Amanda Pacina, are you joining us again?
Actually, she just left, as we said her name.
Okay, sorry, Amanda. Sorry to chase you off.
We have Bob Ario.
Bob? Okay.
Kathy Osborne.
Kathy Osborne.
Yes, I'm here.
Hey, Kathy.
Christine
Okay. That's your mic.
I'm here.
Okay, great. Get some problems with your mic, so I think we're going to
Deb Toes.
Deb Toes? Alakuma or Anthem? Anthem?
Anthem.
Yeah.
Oh.
Jennifer Brady.
Toes.
Jennifer Brady?
I'm here.
Yay. Hey, Howelson. And Lynn Benjamin.
Hi everyone.
Hi, Lynn.
Marilyn Barber.
Marilyn Barber.
I'm right here. Hi.
Anybody else?
That was Jennifer Brady. Randy Cosgrove.
Randy Cosgrove.
And Tatiana Orozco.
And Tatiana Orozco. From Anthem? Yeah. Okay, so we know a bunch of you are out there and you just can't talk to us, but we're glad you're there. And again, please use the text box. And if you're If you're one of the people who can speak with us, make sure that you keep your either your computer mics on mute or your phones on mute so we don't get feedback in the room, and then you can join us when you're ready to say something. Fantastic. So let's start at the top of the agenda here. So this is what we're about here today. So we're going to do a brief, just introductions. We'll do a little review of the agenda here, and then we're gonna get started and dig in. So starting at the top, we're gonna do a little bit of a review of last meeting, some of our action items. We're gonna check in on the CDA website, so you know, again, there's a lot of new people joining us today, so we want to make sure that they're sort of oriented to what's going on with these work groups. And then we're gonna dig in and start working on our IPC revision tool and do some sort of cross-checking of the required elements that the feds are making us insert into this IPC. We're going to talk about person-centered planning in general as we go through, but we're going to work our way through that work tool today. And then, as always, identify overlapping issues. We met with the quality work group this morning. A number of the things that we were talking about clearly point back to how we're tracking data and using data that we have. So as we look at this IPC, we need to think about the quality piece of this as well. So if we could start with the review, Jill, if you would bring up, the first up is the workgroup charter. So we have this is also on our website, but I just want to point out that we made some revisions to this workgroup charter from last meeting. Nothing to the text of it, nothing to what it is we're doing here. We just added all of the new people who volunteered to participate. So thank you to new people who are joining us. And just a reminder that if you want to get caught up fast, we're going to show you some things on the website. You should definitely acquaint yourself with the charter and what our purpose is, and then get out on the website and look at some of the documents we have out there. We have a lot of different resources on person-centered planning and things that are going to help us in this process. So you definitely want to get up to speed with those. So this is our charter. If we could just go up really quickly up to the purpose. So basically there are these 5 main points, and they all pretty much say we're going to change the IPC so that it works better. Okay, it works better and it's up to date. So we're going to get it in line with person-centered planning requirements to the extent we can. We're going to bring it up to date with current program requirements because we started this IPC when we started CBAS, and we've learned a lot of things since then. And we're gonna do what we can to help that IPC work better for facilitating information exchange between the providers and the plans, increase our capacity for documenting and tracking quality measures and clinical outcomes, et cetera, and then improve the form's design and sort of user friendliness. So that's pretty much what we're about in this work group. So let's go ahead and now go out really quickly, and we'll take a look at the website again to make sure that everybody knows that that this is a transparent process. That everything that we're doing here is there's no hidden agendas, or if there is, we can't talk about it. So everything that we're doing is out in the open. We're sharing it with the larger community. Everybody's invited to participate in giving us feedback, but the work group members have actually explicitly told us they're here to work and they're committing to show up and do so. But all the information is out there and available to everybody. Okay, so if we go on to, this is the CBAS landing page on the Department of Aging website. If you're a provider or you're a plan and you don't know this website, you should get acquainted with it because there's a lot of good stuff out here. So the second button in there, HCB settings, stakeholder activities, this is where we've been doing a ton of stuff over this last year. To bring CBAS in line with new federal requirements. So we've been marching to the mandates of CMS, and this is where we have a whole bunch of stuff posted that's of value. What I want to direct your attention to here is under the bullet that says work groups. And so on work groups, that's us, by the way, work groups. And so we have 2 work groups going right now. We have a quality work group and an IPC work group. This is the IPC work group. So if you go to, just really click on meetings, just so you can see. Under meetings, we have all of the meetings listed. This is where we'll have the webinar registration information, et cetera. And where you can click on and you can go and you can hear a recording of this meeting if you absolutely needed to. And you can see any minutes that we post, action items that we post, agendas, etc. So each of the meetings for each of the groups, and then if we go out, we have another spot here called key documents. So the key documents tab for the work groups, because there's another bigger key documents that has all the HCB setting stuff. But this is the key documents for the work groups themselves. So there's the IPC work group and there's the quality work group. So if you click on those the charters are there. But take a look down, because this one always fools me. I think it's a great design on this web page, but I still can't get used to it. But we have our tools under that bar. We have background and reference materials under the next bar. We have websites and links under that bar, and then some policy, laws, regulations, waiver requirements that are back there on that. So again, deep dive. If you want information, it's here. Okay, and then we're going to keep posting stuff as we go through this process, because this process, in case those of you who signed on didn't know this, we're going through June. So we're going to continue to post things as we go. Okay. So next thing, so then we'd like to look at, that's the website. I think all we really want to share about the website for now. Okay. And then if you would go and grab the action items. Oh man, it was a long list. So so here's what we're going to do with the action items. We had a bunch of things that we identified last time in our meeting, because I think the IPC, unlike the quality work group, I think we had a little bit more foundation to lay. With IPC, I think we kind of dove in right away and started thinking about ways we wanted to pull it apart or keep it together or what have you. So we did a walk through the whole IPC. So we came up with a lot of stuff last time. So we'll kind of revisit those things again today. But top of this list of action items from our October meeting was that we were going to revise the workgroup charter. So we did. We made a couple of changes there, very, very minor changes, and then we added the new members. So we already did that. We are going to complete a IPC revision work tool, and we did not do that. So we have a work tool. We are going to start working on it today, but we didn't do anything in between meetings. So there's our confession for the day. So we did get that tool designed, and we're going to start digging in today. Number 3 there on the list is to review the all-plan letter on care coordination and add care coordination to the IPC. I think we're going to be talking about that. It's in our work tool about care coordination requirements. But this all-plan letter, again, for those of you who don't know, the managed care plans get directives from the Department of Health Care Services about what they need to do, policies that are in place, including this one, all-plan letter 14-10, and that specifies care coordination requirements. And so there's a lot of overlap here with what we're doing with CBAS. So this is something that's sort of still pending for us to spend a little time going through. Number 4, we had a review eligibility screening tool and best practice. Dawn, we kind of had that on your list. So again, well, here I'm looking at you, Dawn. Dawn's in the room. I apologize. I did not remind you about this as an action item. So I'll take ownership of this one. We definitely want to take that up. Dawn shared last time that at her center they actually do use a screening tool to, I don't know if it's different from the screening tool that we used originally. Yeah. So, but that you use before you you initiate contact with the plan. So I think maybe we're gonna take another look at that at some point. We could actually do that today if you wanted to. It's up on our website if you wanted to walk us through it, Dawn. I don't want to put you on the spot, but. Yeah. Okay, so we'll come back to that item. You think about that while we're doing this. So establish subgroups for work in between meetings. So again, we had hoped to get some work going in between meetings last time. We will between this meeting and our February meeting, so we haven't yet done that. Number 6 is where when we did our IPC walkthrough, all of us, we had huge amounts of conversation. So there's a lot of items here that I would like to have us discuss as we're approaching the work tool today. So so if we could do that as we dig into the tool. So those are all the sort of action items from last time. Any questions on that? Any feedback on that? Dawn, have you had enough time to think about it?
Yeah, you know what I think it is? I think it's our CADS development tool.
Okay.
I think it's just that
so
one pager.
Is it the one that we have on our website? Because we can go out and take a look at it.
Let's bring her
Can we go out to the website and here? Let me see if I can find it. I hope it's not. It may be archived because it was part of an era
during the transition. That we did during the transition.
Okay, so it was that. Okay, so that's cool. We have that. What did I do here? Let's go. Oh, that's not where I want to go.
It is. These are the tabs at the top.
Oh, okay, thank you. Thank you, appreciate all the technical help I can get. Okay, so let's go to the CVAS landing page, and I believe it's under, let me see, it's going to be under, let's see, program. This is a good way to tour the website here, impromptu. So we've got, is there something here that says eligibility? Eligibility requirements, let's see if it has anything, that's just the requirements. Okay, so let me look, I think it might be under training. Let's go look under training, and then if anybody sees it before me.
Screening.
Okay, so we have screening tools, but help me, is it this one? That's the instructions?
Up. Yeah.
Is this it?
Yeah, that's it.
Great. Okay, I don't know what
Yeah.
that means. Okay,
So,
yes.
yeah,
this
I
is
do
a
get,
test
I
instruction.
think I do get credit for the formatting. Sure. But,
So yeah, tell us a little bit about it, Dawn.
well, this was during the transition. So as a group, this was not my form. This was groupthink. We developed a way to capture the eligibility criteria right from the get-go, so you recognize everything on there, and then identifying them right off the bat, if they were a regional center client or not, MSSP, and then we were looking at NIF-As, NIF-Bs, if you recall, back in that day.
Right.
And then, so if you were NIF-B, you were in. That was automatic. If not, then you began to look at ADLs and IDLs because we were trying to capture the NIF-A. And then
Can I just stop you just for a moment, Dawn, and just remind everybody, because back then we had something we called categorically eligible, the people
Yes,
who moved directly
categorical,
from CVAS
yeah.
from ADHD to CVAS, and these actually are, at least this one right here is a community high risk from the plan's perspective, and this one is a community high risk with the IHSS hours at 195 or more. So just as
so
a
during that initial screening, when everybody went through the process one more time, if you hit one of those four, you were categorically eligible, and the nurses that came on site didn't even need to see the person. And then NIF-B, so then if you weren't, you were presumptively, and then you worked down through there. And so, if you were NIF-B, you were good to go. If you were not, then we began to look at ADLs, IADLs, everything that's listed there. Not all of them, but these were the qualifying ones listed there. And then that brought you down to the eligibility screen for CVAS, non-categorical and non-presumptively eligible. And so if you didn't get qualified in A and B didn't work for you, then you were dependent on something in C, and C being NIF-A, which has always been a tad nebulous and continues to be this very day. Then, and then these are all, we all know these, but for the plans, I guess it may be helpful. The determination tool is something the nurses bring out, and they're looking at these. So, if they have a traumatic brain injury or a chronic mental diagnoses, then you're looking at category 2 there. And so this is their primary diagnosis. And then if they have the diagnosis, the qualifying diagnosis, then you need to look, do they have 2 of the following, ADLs or IADLs? And they're listed there. Or they can have 1 ADL and 1 IADL, which was very helpful in the development of that, as many of our patients with traumatic brain injury or with mental health diagnosis often struggling significantly with IADLs, that's very much impacting their self-sufficiency in the community. And so we have those 2 options. And then 3 and 4 is really looking at the individual with cognitive impairment. 3, I've always thought these were out of order, but 3 being, there's the stages 1 through 7, which is developed by the Alzheimer's Association, and if you hit 5 through 7, there's no need to look at ADLs or IADLs. You're just automatically going to be qualified under category 3. But if you are under 5 and you were 4, then you can look at IADLs and ADLs once more and determine if you have 2 of those that are something less than independent. That's all. It just has to be something less than independent. So on that 4-point scale, it would be 2, 3, or 4. And then the 5th one's not there, which is, well, it's because it's regional center at the top. But at the center now, we've added that down because we don't have categorical eligibility anymore. So there we go. That was the way people. So what centers did at the time is most centers had these all filled out for each one of their participants prior to the plan nurses or state nurses, whoever was coming at that time. Because they were all state nurses at that time, huh?
Yeah, it was state nurses and contract nurses, not plan nurses,
And they would come and we would have these forms all in the charts. We had them all right in the front of the chart, and then the nurses would begin to meet with the participants and look at these forms and find the substantiating documentation inside the chart. And we flagged everything, so it was a pretty user-friendly way to find each of those indicators that were critical for determinations.
Great, thanks for that background, Dawn. And I'm remembering last time we had a conversation about, I think it was at your center, where you had the plan review, they thought the person was eligible, but you guys had done a screening prior and thought they weren't eligible, or maybe it was that you assessed them after. Somehow we were talking about this screening and how you use it.
After the IDT process that we felt that they were.
Okay, so it was after. So in doing screening now, do you use this tool and okay? So
we do use it up front. Our intake person pays attention to this, but it's all kind of, we think, or it's self-reporting, family reporting, and doing the best. And so we have an individual come to the center in what we call a visit day, which many people do, and that's when we're paying much more close attention, and we're able to make a much more solid assessment on whether we are hitting one of these categories, so that we can not go with the family or ourselves any further through the process
before you hook them up with partnership and you get the
exactly. Yeah.
Okay, and you guys do the same thing, so
yeah, we use that as part of our intake process, and then we have the program visit that gets dialed in a little bit deeper.
Okay.
And then I look at that prior to somebody new coming into our program for assessment.
Okay.
Yeah, so we look at it a final time at IDT. So one more time we look at it.
To make sure what category they fit in.
Yeah.
Can I just ask Celine, especially because we talked about HRA's health risk assessments this morning in the quality work group, and do you see any kind of like a, I don't know if it's opportunity, but when you see somebody first and you do a screening on them, at that point, the plan may or may not have, you're not in a CCI County, so you don't have HRAs. What am I thinking? So it's not helpful. I was just trying to think of where the HRA might come into play here in the upfront part of the, the process of getting people.
What's interesting is I was thinking something like this might be a useful tool for us to educate our case managers. Yeah, because
simple.
And then they could take the HRA data and translate it into this.
Yeah.
And it sounds like we have to. I think there's a few terms that we have to be updated.
Yeah, some things that aren't that were relevant to the transition that are kind of outdated now, but yeah, the same structure.
It's simple.
It is
kind of a logic to follow for eligibility. I think it's still really good.
Yes.
There's questions for all the 5 through 7, so that our intake coordinator asked to try to, because it's hard to tell, the levels until you kind of see them at the center, but they basically ask some questions to kind of ferret that one out.
And we actually have an IFA level of care worksheet as well, connected to that.
What, did you guys develop it at the time? Okay,
Yeah.
then let's go out and see if it's still there.
Are all centers still using this, or this was just used primarily?
They were required to do it at the time of the transition for all existing participants. So it's not anything that's been carried forward.
We use it.
It's a good tool.
It's a really good tool to really dial on.
Is that
You don't want to.
Yeah, the dementia screening tools are up here too. That if anybody wanted to use
So Denise,
those.
are you kind of thinking if that were updated and made a standardized screening tool that we could get rid of all that related stuff that's in the IPC? That has all that eligibility.
I wasn't driving any agenda here really. I remember us talking about it last time. It was on our action items list, and I think that was the context. Is that what kinds of things do we sort of pick up right at the beginning, and recognizing that when we get into the IPC, that whole first section is sort of some background information and whatnot, and we might want to consider trimming that down or putting that into another tool or
So I think this would make a great substitute. That would be in the health record, signed off by the IDT.
Mhm. Yeah,
Essentially what the nurses are looking at when they come from the health plan.
right. And, you know, another piece of this discussion, you know, again, I'm not sure how much this relates to this, but the plans are required when they do face-to-faces to use the CVAS eligibility determination tool, the CEDT, and that was a standardized process that, again, was, you know, probably more relevant to the transition. Now some of the plans are wanting to, you know, do more approvals for enrollment without doing face-to-face based on their own data and whatnot. So we might want to try to revisit the CEDT at, you know, at some point.
Well, I think this is Lydia speaking. The reason for that would be that for future auditing purposes even, because the plans get audited and they can audit the centers, it'd be good to have tools that really match up.
Yes.
And that have been validated by the payor as well as the clinicians, and it just starts to make a little more sense. I think it could simplify some of the conversations around eligibility, screening.
And some of the questions that are coming up, and I don't have the answers to them, from the plans that are looking at waiving the face-to-face, having policies and procedures in place that say we're going to automatically make someone eligible under the following circumstances. They write their P&Ps, et cetera. Then they call us and they say, do we have to use the CEDT if we're going to be doing this? And that's like, I don't know. The CEDT is actually a face-to-face tool. And from the folks that I have talked to, there's been an interest in making sure that they complete it anyways, even though as a substantiating document about their decision. But again, I don't think there's any policy clarification on that at all. And how do the plans make sure that they have got somebody who's eligible and are able to say this person meets the medical necessity and eligibility?
So it sounds like there's currently duplication, almost triple duplication of the eligibility. Because you see that tool?
Yeah.
There's, you know, managed care is doing their own, and then you know potentially then we're also doing it on the IPC. Yeah. That's I mean,
yeah, there's a lot of duplication of effort.
And my thing on the IPC is start at zero and put in what we need.
Yeah.
And then as opposed to looking at it and taking it off.
Right. So. Okay, so got some comments from the webinar.
Yes, Diane says the full information for the EDT might not be available until after the center does their assessments. When it was first used, it was with existing participants on which we had complete information.
Right. So Diane's comment, when we did the transition and we used that standardized tool for eligibility determinations, I think in theory it was supposed to be used as a observational and an interview tool that the nurses were ticking off, and they weren't supposed to be looking at the health records, because I think, again, that the expectation was we're trying to get a objective snapshot of the person's level of eligibility without having the health record documentation in any way, you know, sort of skew that perception. That was the way it was supposed to be used. I think now it clearly, you know, when you're talking about new people, you're always talking about somebody who doesn't have a health record. They may have an H&P, and the plan almost always has some data on those people. So it's kind of a new world. So we need to update a few things. I don't want to take us too far off track here, but I did want to just sort of revisit this because it was one of our action items from before, and it's just something to, you know, something to think about as we work on the IPC. We think about IPC revisions and how we want to approach it, that we do have a number of points where we're collecting information on these beneficiaries.
Lynn has a
Lynn,
comment.
Yeah.
Can this tool be used by the centers to begin risk stratification that correlates with the risk stratification process criteria that managed care plans use? Risk assessment will continue through the initial assessment process and ongoing assessment process.
It's a good thought. Why are you saying no, Lydia?
No, I don't think this matches up at all with risk stratification.
Okay.
Plans are doing. Still, I mean, it's a great thought if we could get to that, but I think the elements that are in there today are not, you know, aligned with what the plans are getting from the state.
So for existing CVAS participants, they're already risk stratified as high risk in CCI counties.
Right.
Okay. So we would be talking about as the new people come in, then the plans are in a position of deciding what their risk level is and maybe referring and coordinating and linking up with CVAS. And then they would become high risk again. So those individuals would be coming in as...
I was kind of thinking that the case managers actually have the data that tells them what came out of the health risk assessment or what came out of the utilization screen or whatever. I think that's where they're knowing what's coming out of the HRA. They're almost like a bridge to this, where then they would say, oh, look at all those ADL impairments. It's going to be a CBS person. So I was thinking of it as a tool for the case managers.
That's what I was thinking.
Yeah. But you need a person in between the data sets, kind of, in a way. Like you need.
Yeah.
We don't. I mean, maybe in a future world, you could somehow the HRA data would translate, right into a CBS referral. But right now, we don't have that. But we can't educate the people that are.
So does the HRA get at functional ADL functions at all, or it does? Okay, so that would be one piece of it. It gets at, you already have some diagnosis data. So you would be able to, based on just some of that, understand whether there's individuals that meet the eligibility, big categories, and then it's a question of whether they have a need for CBAS based on their individual.
I mean, your IT people could put flags on certain things that are clearly high risk,
Yeah.
whether it's IHSS or CBAS, but there's certain things everyone knows are high risk.
Right.
And if they could flag those, and they'd pop out with people.
And if maybe somehow we tied it to what makes someone eligible for CBAS.
Down the road.
No, I think
That's an IT exercise.
Yeah. Before you guys do your before you do your risk assessments, do you have IHSS data for people who have IHSS? So would you have functional assessment data?
I don't know. I don't think. Well, we have the state file for people in IHSS, but I don't think we have.
You just have the individuals identified with their
county
functional.
level. I'm not sure about that.
And that would be an interesting link right there. Okay. Any more questions or thoughts on this? Saw some feedback come in. Okay. So let's, next up on the agenda, we had that we wanted to just get started sort of actually picking up where we left off last time when we were walking through the IPC, and we most of us, I think, in here made scribbles all over our IPCs. We translated those scribbles into the list that's on the action items. And actually, why don't you pull that up before we get into the work tool? Let's go to the action items. And let's look at those IPC revisions, or as we said, issues that we identified as requiring more conversation. So as sort of set up to another level of walkthrough of the IPC, because again, to remind you guys all, at the end of this process, what we hope is we're going to have, some consensus from this group about what we want a new IPC to look like. All the fields are included, the layout, etc. And then, I think that what we amended on our charter last time is that we want to have this group also look at how do we implement this thing, including getting training out there and bringing everybody up to speed with it. So we want to make sure that we're still, sort of moving in this direction of identifying all the changes, and then at some point we will have enough information that we've all gone through together and decisions we've made, and we'll have a prototype that we develop. Okay, so that's our end game. Okay, so IPC revisions here that we identified last time. So we said that we were going to we needed to identify audiences for the IPC regarding its purpose. As in the plans use it for authorization purposes, possibly for some level of care coordination, and the providers use it for implementing services, state uses it to monitor the services, et cetera. So there's various audiences, so we need to consider that as we go through this obvious statement. What info do managed care plans need? So again, I think that we're looking to get the, sort of the morning conversation about HRAs and some of the things that you guys are doing and getting to know your members and their level of risk, et cetera. That what do we need to consider about the plan's needs in putting new things into the IPC, or making sure that we cross up with similar data fields. IPC and eligibility. So eligibility is, I think that was a question that we had a lot of conversation about last time, because we've got the eligibility criteria writ large in the IPC now. I think that we were talking last time about a more compact, leaving the IPC eligibility criteria in the IPC, but just having sort of the check boxes, so we're validating where we believe they belong eligibility-wise, but not having that long list of confusing circles. Actually, they're circles, not boxes. So we talked about that. Primary and secondary diagnoses, we had some questions about that. The way that they're currently broken down is primary and secondary. We wanted to talk more about that box 10 about mental health services, so that's a big flag. We need to revisit some of that. Capture the planned and unplanned emergent care. Use the IPC as communication tool about other service needs and services utilized. So again, is it more of a coordination tool? Clarifying the hierarchy of person-centered plans versus the IPC. So we had some conversation about that. Where does the CBAS IPC fit in the larger scheme of person-centered plans, and what the managed care plans are doing with the IPCs? Capture a full week of CBAS participant services outside CBAS Center. I'm not sure exactly what that referred to, but I think we were talking about how we only have the participants at the center for a certain period of time, and that somehow having a way to capture some of the other things that are happening outside the center might provide meaningful information for authorization purposes and care purposes. Review previous iterations of the IPC, what has changed. We have not done that. I'm going to flag that as a to-do, that I think we need to go back and look at some of those things, because I think that we did some things in past iterations of the IPC, and then we changed it, and that we might want to go back to some of the things. Like I know progress on goals is one of the old ones, but we didn't do that. So I flagged that one right now for our follow-up items. Discuss summary page, the purpose, and the audience. Okay, so for those of you who weren't here last time, the summary page, some people love to write long narratives. Some people think that they've been instructed to write long narrative in the past, and so they've continued doing it. Others are following the instructions in the manual that say only add things that we haven't covered elsewhere in the care plan, so they keep it brief or put nothing at all. So I think that we're trying to look at standardizing how we approach that last summary box. That was a really spirited discussion, I remember. If people are passionate about the initial information box, it's good to have some passion about something here. The purpose and audience for that summary page. Okay, identify other supporting documents to the IPC. This is actually my subject, near and dear to my heart, that I want to look at. What can we offload from the IPC to meet some of the person-centered planning requirements, but not have it be part of the care plan? So thinking about a standardized participation agreement, I'm all for that. And that's going to start Diane sending texts saying, oh, as soon as I say that. Okay. Clarify language using the IPC, problem statement, needs, strength-based, functional language, level of functioning, diagnoses, balance, strength. Okay, so these are like, how do we get more clarification around sort of how to put in baselines, I think, and use uniform language. CBAS alone can't address all needs and use partners. I'm not sure what that meant. Address care coordination. Okay, so again, we want to see how we can weave care coordination into the care plan. Identify measurable outcomes and behavioral anchors. And so better get at some measurable outcomes. Eliminate duplication. So if there's anything duplicate and anybody sees it as we go through, please cross it, tell us to cross it off. What's the minimal amount of information to meet the requirements? Okay, so do we want to go minimalist here? Or do we want, Amanda's an advocate for that, and start at zero, and others who say we got a lot of good stuff in there, let's keep it and see how we can tap into it. So we need to think about that. Identify the right level and frequency of services. Sounds good. I'm not sure how we do that. Identify what kind of measurements and how for rates of frequency. I think that gets to sort of some more formulaic approach to what translates into how much service is needed. ICD-10s and social determinant health codes. Yeah, I know we talked about that, how we can work more of the social determinants of health and risk factors in there. How to identify, stratify risk. Okay, we've talked a lot about that. How does need, risk translate into days of service? That goes back to that level of service, and how do we determine levels of service need, how many days per week are authorized, how many days to achieve the goals, consider different approach to care planning, interdisciplinary team model, and I think we're going to talk a lot about that today. So those were a long list of things that came up last time. Anybody have any comments on those preliminary digging in? I know. Okay, good luck. Well, I mean, we had a lot of good thoughts last time, and we captured them, and we captured them, and I think that this is what needs to inform us to go through, and now we actually start trying to make some decisions. Okay, so that's kind of where we are. So to that end, let's see. It's next up is to complete the IPC revision work tool, and to do what we can to complete it. So, oh good, we're not too bad. We've got the wrong timelines on this agenda. Okay, we said we started at 1. We actually started at 1:30. So now I'm not going to know where we are on the time clock. So Okay, so let's pop, if you could pop the agenda back up again. So
Just a half hour later than what was.
yeah, we're supposed to end at 4:30, aren't we? No, we're supposed to end at 4. Why does it say 1:20? So is that supposed to say 2:20? Where we are complete the IPC revision tool?
1:30, 1:40,
This is probably supposed to be.
Okay, I'm confused. We have the rest of the time until just about the end of the meeting to work on it. Okay. You can see how easily I make adjustments. Okay, so
About an hour and a half.
okay. So what we want to do, I think, again, reading through that exhaustive list was all preliminary to looking at this work tool, if you pull the work tool up. And then also a part of this discussion of getting through the work tool also includes sort of revisiting this sort of bigger subject. And I think Amanda sent some information out to you guys about, and I know there's been a lot of conversation about it. I had a lot of people come up to me at conference and talk to me about what's happening with person-centered planning and where are we with various things, where's the department on these kinds of issues, and I would just say we're not there yet. So we're partly going to get there through these conversations and all of us informing one another about how we're looking at the output for person-centered planning in the IPC. So why don't you just orient us to the tool again, and then I think what I'd like to do is maybe sort of open up the floor to a conversation about the interdisciplinary approach versus the multidisciplinary approach, the boxes the way they are on the care plan, the boxes rebuilt so that they look at, from a problem and goal-based kind of a setup, stuff that you know a lot more about than I do. We'll open up that to the conversation. But I want to just go over this. This is a work tool that we popped up on our website, so it's up there right now. It still says draft on it. My version does, anyways. And what I would like us to think about is, just like with the quality work group, we have to start working towards a product here. And so what we've tried to do is in this document, first column, is to lay out the federal directives, the requirements that we're mandated to do. So we want to revise the IP irrespective of what CMS says. Okay, I have for some time. There's confusing boxes. People call me and ask me how to fill them out, and I say I don't know. Okay, so that's not a good position for me to be in. So we've wanted to do this, before CMS started getting in our business. So now we have some new federal mandates. So in addition to that, so what we've tried to do is lay those out in the first column. So in our CBAS waiver, what it says is that we have to have, and it also says this in the home and community-based settings requirements under person-centered planning. It says that we have to have certain things done. So we have to have a care plan that identifies the enrollee's preferences, choices, abilities, strategies to address those preferences, choices, and abilities. So that's like the giant, that's the giant category of things that have to change. And then we have sort of listed all those things. If you could scroll down, Jill, we've got 1, 2, 3, and 4. Those are all very explicit things that are listed in our waiver that we have to do somehow, somewhere. Okay? So we want to walk through an exercise with you guys of thinking about that, and some of it's going to happen between meetings, and because this room is too hot and the day is too short, we can't get through it today. But that's ultimately what the task is going to have to do. We've got to identify what they want us to do and where we want to put it. All right. And then if you go down to page 3. These are still requirements for person-centered planning that are in the home community-based settings requirements. So we've got the federal directives listed there, and so if you go through, here's the person-centered process that's all defined. So these, again, we didn't make these up. These are straight out of the federal regulations. Plans also have to be, thinking about these things. So what are we doing at the CBAS level to address these federal requirements? So you can sort of walk through all of those. There's a bunch of them. I think there's 9 of them. And then we get into what the federal requirements say about the plan itself. So that's the process, what has to come out of the process, then what has to be in the plan. And again, there's more language in the tool. If you keep scrolling down, I'm on page 9 now. If you go down and catch up a little bit with me. So that's the plan itself and what has to be in there. So again, these are all things, some of them we already meet, so we have risk factors and measures that are in place to minimize, and we have risk factors in our current IPC. And then if we get down to the very end of the document, it starts going through the plan itself. Hello? Somebody trying to participate?
I
Okay.
have some comments too.
Okay. Okay, so basically that's the overview of the first column of the tool. It's all the things that we're being charged to do, okay? Second column here in the middle, actually, we've got a one column split in half, and we say in that first part of it, IPC revision, if you could go right there, put your little cursor there, IPC revision. So we're just saying, here's the requirement, what we have to do. Do we need to revise the IPC or not? So, because I think some of these questions, we're just going to say, no, we don't need to revise it because it's already there. Yeah. Or, no, we don't need to revise it because we're going to address that somewhere else. It's already addressed, that issue is already taken care of. Or this is all process, it's not the IPC itself. So we're going to say yes or no, there's a revision. And then if we say yes, there is, and we know where it goes, then we're just going to state it. So again, this is what we're thinking, work tool-wise. So that's basically that column. And then the next column over is to consider, well, are there other documents or activities that we need to consider to address this? So if it has to do with making sure that the participant is informed of choices, for example. So we're going to have choices reflected, to some degree in the IPC. And then we want to think about, well, is that something that involves maybe a change to our participation agreement? Is it something that we standardize that, or is there something in a policy and procedure that we need to address? Are there other places where we need to talk about addressing this? And again, then we think about how we're going to do that. Are we going to provide training to providers to just make sure they do it, or are we going to standardize a form, et cetera? But there are other ways of getting at these requirements. Yes, Don.
I just think a key bullet there in that third other documents or activities should be the assessments, the individual assessments, because I think that's going to be key to the answer of many of these, of where that other documents or activities.
Nice. Yep. Fantastic. You want to just add that now, Jill?
Yeah.
We can. Yeah, that'd be great. Just put
Is this a header?
Yeah, I don't know if it is or not. Right after training, you can try putting in assessments right there. Yeah. Great. Okay. Anybody else with some input on the tool, Lydia?
Not on the tool right now, but
okay.
A new resource that's just come out is from the SCAN Foundation. There are a couple of good papers on person-centered. I don't know if anyone else has seen them. I think they just were issued, but I've got both of them opened up here, and one thing I wanted to read to you from this is, although there is no one-size-fits-all model that can simply be rolled out across the country, the key to success will be fidelity in implementing most of the elements of person-centered care programs that the American Geriatric Society has identified. So that just relates to our conversation earlier today about there's really not a one-size-fits-all. And one of the programs mentioned is having models that greatly embrace the AGS person-centered care elements is PACE. And of course, we know adult day health care is a key foundational piece of PACE. So I think that just, again, supports our earlier conversations that a lot of these elements we've already got in place. And, kind of don't mess with the things that work.
Yeah, right.
So anyway, these are good articles. I'll shoot them over to you and you guys.
Yeah, I think that we saw, did they come out on a SCAN, email update? Because I think that I got them. This wasn't something just today, was it? It was like last week?
Might have been, I don't remember when it
I think that it's send it to me just in case, but we'll make sure that we put it up on the website so everybody can see it.
So good reference articles there.
What do we have online?
Diane has a couple comments, and a couple more kind of interjected a few minutes ago. So one is, this takes us back to that question of whether the person-centered plan is the same thing as the IPC. I don't believe that they're synonymous. And then the IPC results as part of the overall person-centered planning process, but represents only the formal commitment to provide certain services.
Yeah. And I think, to Diane's comment there, I think that's why when we built this work tool, one of the things we were thinking about is that where else might this better fit for us? I mean, I think that there's a lot of stuff that, frankly, is part of our consent for services, our participation agreement, and if we were to put together a recommended standard template or actually a required standard template for participation agreements that included these things, a number of these things could be addressed probably more appropriately in that form,
Right.
So.
And I mean, the thing is when you look at how are each enrollee's preferences, choices, and abilities and strengths, that's, and also to provide, the other one that I'm thinking of is the informed choices. How do you put that on an IPC when,
Right.
for me, the goal is to cut it down? But it would certainly be in the policy and procedure, that the participants' choices in their IPC or in their plan of care is provided to them.
Right.
What kind of services
Yeah.
do you want?
Yeah.
And that would be in a policy and procedure.
Sure. Sure. So there's a number of other places where we need to consider, and yet it's not the charge of this work group to expand out and start doing all those things, but I think identifying them, and then we can say, this is how we've had them, how we've gotten these things addressed. Selena, did you have something?
The only thing is that the IPC is the formal document
Yeah.
that we receive as
Yeah.
a health plan and
Yeah.
not necessarily all of the other assessments. So if we're looking at, is person-centered care, person-centered planning taking place, we're really looking at the IPC
Yeah.
for the most part.
Right. So this goes to that question that we had last time about there's multiple audiences for this document, so we need to consider that as we do it too.
And I would suggest that if the care plan is written correctly, and the actual plan of care piece of it is written correctly and written well, that it will be reflected.
You can see that it is a person-centered plan. Okay, Gretchen?
Well, you guys all know the answer to this, but are you currently doing this on, is it electronic format, or is everybody using paper? Or?
So providers could respond to this better than I am. Many of the providers use software vendors who have IPCs that are generated through their electronic software systems. So, but we do have some providers around the state that still do it the old-fashioned way.
Not handwriting.
I do believe we do.
Yes.
Well,
There are still some.
Okay, any more comments on this?
I have a quick question.
Yeah.
None of the managed care providers that are here are ours, but are your centers able to upload the IPCs to you now? They can.
We're just rolling out that process.
Okay.
Yeah.
Boy, because that sure would be great and beneficial for the centers.
So can I ask a clarification on that? Are they uploading an electronic document or are they uploading a picture?
As PDF.
CM, yeah, okay. So again, I mean, going to the sort of next stage is thinking about what kinds of electronic capture that we can consider. And how might we get there yet? Yeah, it's not here yet, but
10 million.
got to keep our eyes on the future.
Do it.
Got to keep tuned to the future. Okay. All right, any more comments on this? Okay, then what I would like to do, if I could, is to just start us off on the conversation about, well, first of all, let's do this, because I do know we have a lot of new people that are involved in this work group, so just by way of a little bit of review, if I could just pull the IPC up and have us do a little bit of a walkthrough. Okay, so, and then that would be sort of preliminary to digging into some of the meatier issues. So yeah, if you would, I think I've got it in the documents file. If not, we can go online and get it. It should be a Word version of the document.
Yeah, I think you have it in here.
There it is. Yeah, right. Very good.
Denise, I have just one more thing. I think when we look at this, when we talk about audiences, we also
Yes.
have to think about the individuals that are completing this
Yes.
tool. And in the perfect world, everyone would be literate and could write great care plans, but in the
Sure.
real world, that doesn't always happen.
Right.
I'm sure you won't see that. So we have to make sure that it's put together in a manner that all of the social workers and all of the nurses can get the information on that care plan, not only for the center's benefit or the benefit of the participant, but what managed care needs and what state needs. Without it having to be this big literary tool.
Sure. I think it's great feedback, and one of the things that
Everybody can write. You know.
one of the things that we are, intending to do is to, when we get a little bit farther along as a work group, is that we'll bring our software vendors in to participate in the discussion about sort of output, because they're the ones who are going to have to retool their software programs to give this to us. So what you're getting at might be a combination of what the expectations are around how things are actually written, and then it also might be around what kinds of sort of user-friendly mechanisms can be in the software so that the output looks, it's more abbreviated. Yeah.
Which I just want to remind everyone that all adds up to dollars.
Yes.
So whether it's dollars and cents of the software vendors having
Yes.
to up training for the
Right.
providers, I mean, everything
Yeah.
that we change on a standardized tool equates to dollar signs. So
Yeah.
that's why this work's important to think through.
Right, and so definitely got that in mind and want to make sure that our TurboTAR and our RTZ and CoreLink folks are at the table sort of participating in how extensive the revise of the format is. Yeah. Okay, so if we could just really quickly here, let me just overview for people in the audience and then for everybody today just by way of review. So the sort of main sections of this IPC. First of all, it is 15 pages long, and then once you fill it out, it's even longer. Okay, so you know, the historical complaints over the years, this is a very, very long document. Okay, some of it is space that can easily be fixed by eliminating the eligibility criteria, which are very long. So we start out at the beginning just talking about basic information about who the person is in the header and what the planned days are, whether this is initial TAR, re-auth, et cetera. We go through diagnoses, medications, so background information, the physician, personal care physician information, and then we get into those eligibility criteria here that are really, really lengthy and kind of confusing, and the boxes don't line up, and it's a big mess. Hey, we were in the middle of a lawsuit. We all were in a hurry. You know? So box 5, 6, 7, 8, and 9 are all eligibility criteria. So that could be all basically one box. Okay, so that's all that front part of the document. Then we get into, starting with box 10, we get into some more sort of functional levels and other services that the person's receiving. So we're going through and checking off what's happening with their services for county mental health in the community, what's happening with their ADL, IADL functional levels, other assistive devices that they use, continence levels, feeding information about other non-CBAS center supports that they get in the community, IHSS, targeted case management, various things there. I think some of those categories actually need to be changed or updated. The non-CBAS support services, more identified here, urgent care, mental health services, emergency department, et cetera. Box 17 is risk factors. So this whole section in the middle of the document really is about what kinds of services they're already getting and what levels of risk and other needs that they have. And then we get into I think some more sort of useless boxes under 19, where we have where we're actually asking. This is identifying basically the core services for those of you guys who are familiar with core services. And once upon a time, I think there was thinking within DHCS for the TAR authorization purposes for Medi-Cal that we would be looking at having the center say, yes, we meet the professional nursing services, which if you don't, you're not going to get in anyways. So they're always a yes, but that we would have people providers identifying in the TAR that are in the IPC itself that we put a code N5 that we are providing professional level interventions of services. We're doing the professional level nursing the skilled nursing is defined as the invasive procedures, et cetera. So that we actually thought, I think at one time, that providers were going to be using this coding, and that's never actually happened. So, I mean, we could consider using that in the future, and that might be something that was worth tracking from a quality perspective. I don't know, but I can tell you that it's not happening today. Lydia, did you have a thought?
Well, I was just going to say the historic rationale behind this too was it related to unbundled services,
yes,
rate development, which never happened, and auditing. So that, you know, by checking yes, you were attesting that one of those 5 services was being provided, and if the documentation showed they weren't, you were going to have an audit exception.
Right, right.
So there's a lot of historic baggage related to all of that, but you know, whether it's still useful or not,
right,
I'm not one to say.
And again, I think that goes to that who's the audience for this tool. And it used to be that DHCS Audits and Investigation was a big audience for this IPC. So that's another sort of discussion for our DHCS colleagues at some point to see, you know, whether they're, but I don't think that this is as much a tool that they would be using if they were doing audits. They're auditing the managed care plans. They're not auditing our centers as much. They still can and do, but
right. But to the extent they're auditing the managed care plans, and the managed care plans are not really looking at this closely, and
Right. These are all related issues. Yeah, yeah. It's something to consider. But again, so by way of the walkthrough, we've got a lot of stuff here. So Lydia, you might be making the argument. There might be an argument in there ultimately that we do keep something here. But I would say it probably could be compressed.
Oh yeah. I'm just saying historically that's what I mean.
Sure.
So if we care about things matching up and auditing, something to keep in mind.
Yes, something to
I
keep
don't have a
in
strong
mind.
opinion on these.
Yeah. Okay. If you don't have a strong opinion, you're the only one in the room. I'm just teasing you. Okay. So, and then this box 20 is just, for TAR reauthorizations, you're basically saying, here's just one more criteria that's in the law about reauthorization. So you get in the door with a certain set of medical necessity criteria, and then you stay in if you can say, this is a reauthorization, the participant's condition would likely deteriorate if CBAS weren't there. So, and that goes to it goes to auditing, but it also goes to something that I think CBAS providers believe in their heart of hearts, which is that, hey, we got this person, they were in a mess of trouble, we got them all stabilized. Now don't pull out the services from underneath them, because without CBAS, things would fall apart. Yeah. So that box kind of goes to that. So maybe that box actually could be blown out a little bit, and there could be more information in there that supports that. Who knows?
And certainly the summary box.
And the summary box, yeah. But this would be actually a check box versus a narrative box for tracking information. Yeah, Lois.
Either that, or it could just be in the very beginning, on the very first page, where you say it's a reauthorization.
Yeah. Right. So reordering of it. Yeah.
Just have it be there, and that it's sort of a simple statement.
Yeah, that kind of makes sense too. Okay, so that sort of concludes the middle section of the TAR. And then the next section of the TAR is actually the care plan. So it takes us the first however many pages to get to the care plan. So we have comments from the webinar folks.
Diane.
Well, first of all, I actually wanted to just suggest, can we just agree to remove those criteria boxes right now?
Okay.
Then I would like to suggest that we look at a mock-up of an IPC at the next meeting with all of that type of box removed.
Okay.
That were included to ensure that the center was attesting to providing the requirements.
Okay, so Diane's arguing for a prototype by next meeting. I don't know.
I just say let's to go with that Diane. What Diane is saying. Does participant meet eligibility requirements? Yes or no? Yes. Take care of all those pages in box 20.
So that's why that's
whole
starting at
section.
5, so 5, 6, 7, all the categories.
This whole, thing.
Okay, so I think that we're going to have to hold that until we get through the rest of the debate today. But I think that we could probably start looking at some really basic prototypes where we either compact it down, where we leave in the criteria in one version, we compact it down to one just checkbox. We can take a look at a couple things. But I guess overall, I'd say when it comes to the redesign and the prototyping, I think we really do need some help from our software vendors and some people who have some better sense about this. But we can just take a look at what it would look like to have a more compact document. So we'll work on that request. Does Diane have anything else?
Not at the moment.
Is there anybody else out there in webinar land that has anything to add to this discussion at this point? You can jump on the line and talk to us.
Raise your hand.
Or you can raise your hand and talk to us, or you can send us a text. Or text. Getting confused. Okay, so we'll keep moving then, and please invite you to participate. Love hearing from Diane, but I know there's a bunch more of you out there too. So jump on into the conversation. So this section here is the care plan itself. So this is where we have right now each of the disciplines in the center that's providing services, and then what the problems are that they're addressing, treatments and interventions, the frequency of treatments and interventions, and then specific goals and objectives of the treatment. So for each of the disciplines, we have boxes that are filled out, personal care services filled out by the nurse, social services, therapeutic activities, so that's activities, maintenance program, are identified there, and then there's some diet boxes, and those are what are known as the core service package. So those are the daily required services. And then we have the additional services, PT, OT, speech, dietary services, mental health services, and anything else that you're filling in there. And then we come to the last section. So we think of the 4 sections. First is introduction to the participant. Second is eligibility criteria, actually 5. Third is all of the sort of risk factors and additional services are being provided. Fourth is the care plan itself. And then we'll just call the 5th the additional information box. So this is where all the other, this is the repository for everything else you want to tell. You want to tell the authorizing plan. You want to tell each other for the purpose of providing planning services, etc. This is where you put everything else in the way of an explanation of what's happening with this individual. Actually, then let's just say the 6th section. This is the signature page. So the signature page where all the professional staff sign off, the program director signs off and attests that everything was done per the requirements, and sign a date and send it off. So that is that's the sort of walkthrough of the existing IPC. There's a lot of stuff here, and so I think it's helpful to sort of think about the sections in chunks. Anybody else? Any comments on that?
We have one problem that I just noticed. Speak up. You have to have the physician or the nurse practitioner or the PA sign off on it, and it's so wordy that I watch them sign off like they don't really engage. It's really hard to get them to be really, truly part of the team the way it's written. So if we designed it for them to be more encouraged to be able to leaf through it quickly with their limited time and really kind of track the progress, that would be really helpful.
Okay, can you help us with what that might look like?
Yes, eliminating all those first boxes. Same thing we already talked about, but I mean, it's just another reason that it needs to be more streamlined so that we can have better partnerships with our care providers.
Okay.
Yeah.
Yeah, Lois.
You know, I think that another piece that we've started in my center, we've started using that back section a lot because I said this is useless with these check boxes without knowing who this person is and what's happened to them. So I've made my staff, much to their dismay, write a little summary, like, you know, this person is doing well, this person isn't doing well, this person has had, you know, changes at home that have made this happen, that happen, you know, dementia's increasing, you know, whatever. Because I read every one of these,
Helps you.
and I say, you know, when I get there, when I'm done with this, I want to know who this person is,
right.
What happened to this person,
right.
What are they doing, what's likely to happen to them, and there's nothing in all of these pages that says anything about that.
Okay.
That's extremely clinical.
So
extremely medical based.
It is, and it really doesn't talk about who the person is as a human being, which is what we need for doing a care plan. And it's also, I think, what the plans need for understanding why we're doing what we're doing.
Right.
So, I mean, there's a whole piece that's like missing.
Right.
I mean, I agree with you, Amanda, that we need to start at 0 and build up. But I think somehow we're missing, the person is missing in here.
Yeah. Okay.
And I don't know, I'm not quite sure how we find that person, or maybe that person doesn't have to be in here. Maybe it needs to be. I was just talking to Don and Celine that they do at their IDT, they do a little summary, and maybe that's the appropriate place for it. And maybe the IDT summary then would be part of this. But there's somehow it doesn't get the person. There's no person in this whole thing.
Right.
Except for box 23, is that what you're saying?
Yeah.
Right. I mean, that's what I forced myself. They're like, we never did anything in here before. I said, this is useless, all these check boxes.
Right. I think Diane could speak to it. I believe in the olden days, that was a very key box, right, Tom? Where you had to filled out all
you
the
had to
time.
have your discharge plan in there, and you had to have quite a bit. But I'm actually not in favor of that box. So
well, I mean, another way
I feel I feel all that. Your point is very well taken, and I do agree with that. But I'm not so sure we have to present the world in this document. But I know the perspectives of plans is very important, but I also think it's a lot of duplication when we as an IGT and a staff, we have it all in the chart, we understand those things. How much has to be retranslated in this document, and that's why I've always found box 23 to be just an exercise in English language.
Yeah.
And I used to, before when it was required, and I used to, whatever, I tell people, look at the IPC is like a skeleton of, and with all the information you get from a skeleton about a human being, where the narrative was the flesh and the muscle and the, everything else. And just hearing the two of you, what if we looked at the narrative as bullet points? Because I do think it's so important for the managed care companies to see this as a human being too. And perhaps the care plan, if could be enough, and if it's not, just bullet points. Mary's father or Mary's goldfish died this week, last month, and she's been very sad. Or she moved from her apartment to her son's house, and just to indicate, just kind of bullet points, kind of as another option, kind of an in-between option, to kind of build this human being out.
Lydia. Oh, sorry.
So my remark was going to be originally, way back when, we used that box to justify or to paint the picture of the participant, why they needed our services. The world has changed a little bit. Now the participant doesn't come at all until they've already been approved to come to our service.
Right.
So when we talk about painting the picture of who this participant is, I'm not saying that doesn't need to be in our chart somewhere, right? I don't know that it needs to be in this because they're not coming until managed care says they can come.
And they've done it
and they've already done it face-to-face. For the physician, maybe the physician needs something because they don't always know who they're treating. But
Go ahead.
That's different,
Lydia, and then
Well,
and then
I had a thought because with our community-based telephone, we are using a best practice of SBAR. And I'm wondering, this would be maybe to Dawn and Diane, Celine's gone now, is there any other, if that might be a way to frame what's in the treatment boxes now, because it might appeal, A, to the physicians, somebody mentioned, B, it does describe the person a little bit more, situation, background, assessment, recommendation. And maybe that's, it's a very well-accepted method of identifying problems. So something just to think about, it just came to mind as I was listening to all you guys talking.
Because I don't know what that is you're talking about.
SBAR is a recognized method of quickly communicating patient. I'll use the word patient because it's used a little more in the medical setting. It's a quick way of communicating and a clear way of communicating what a patient's particular situation is.
Is it like
that
SOAP?
moment.
Is it a way of documenting?
It's different from SOAP, but I guess you could think of it similarly. So that's all. I'm just throwing that out for us for another discussion. Is think about, are there some highly accepted ways of framing this that might be useful to us, and I think would address both of what you're both saying, because I think it's more descriptive than what we have today, but it doesn't involve a whole lot of narrative. So I don't know. Something
I do think queuing would be helpful.
Queuing. Okay, so before we get to Gretchen, I just want to throw this in here because I think that I shared this last time because this goes to when we're all done with this process and we've got this new IPC and that we agreed as a group we're going to have a training strategy too. So a training issue. Right now in the Medi-Cal inpatient outpatient provider manual, instructions for the IPC, box 23. This is an optional open text box for communication of any additional information that may assist in justifying eligibility, medical necessity criteria. It goes to what you were saying, Liz. For requested CVAS services. Do not repeat information previously explained. Indicate the box number of the IPC that is being discussed. So this is the place where, for example, if you had somebody who was a intravenous feeder or something and you weren't serving them a meal and that was elsewhere in the IPC, so you'd say, here's what's happening based on box 16, here's what's happening based on the special diet box, and you would be explaining it, but there's no expectation right now that there's additional information provided. So it goes to how we train to it. Hang on, Ken, we'll get Gretchen, sorry.
Okay, so Selena, I'm going to have you jump in too.
Yeah.
But so we are now through the state process being asked to do this, what we call assessment of the assessment, where we're going to have to look at, if they're NIHSS and MSSP and CBS, we've got to look across their planning. And I think the plans are doing it different ways, but we're going to be using an outside vendor to start with. And one thing that's occurring to me as we're doing this is, so our vendor is thinking they're going to use optical scanning just to pick up handwriting and other things. And my guess is that as we start this process, the health plans will suddenly realize that there might be a more efficient way to integrate all this. Okay.
Yeah.
So one thought I had, I don't know whether this would be appropriate at this point, but I'm wondering if maybe we need to overlay that a little bit against this so that, like, while we're working on it, you guys are getting input from the plans on what they're going to kind of be up against on this. Because right now we can see that we're going to be picking up all this handwritten information from all the different, and we're going to, if they're in a couple different programs that have all these long assessment and ICPs, then we're going to basically IPCs. We're going to basically be really dealing with a lot of overlapping information.
Yeah. And if I could, before Selena jumps in, I'm just going to introduce our director, Laura Connolly, who slipped into the room while we weren't paying attention. And I think that's a perfect cue for you with universal assessment because Laura's very busy at work on that. So.
And it is one of the things that we are talking about across our programs and how much, I know certainly from IHSS perspective, how much really was in the narrative notes and what would be helpful to get out of narrative notes and actually into a format because the narrative notes don't get communicated to the plans. So we are conscious of that, but actually all these discussions that I pop in and out of are really helpful because they are cross-cutting in terms of our discussions with the researchers that are involved in our universal assessment efforts and our cross-departmental efforts. So I just appreciate all of you being here and provide. And just want you to know that we also go beyond this.
Definitely beyond this room. So.
Beyond this room. Right.
Okay.
Go with me.
Thanks for popping in, Laura. Okay, so Selena, and then I think we had some questions online that we need to do.
Earlier we talked about we're starting to collect the care plans via upload, but it's still just a snapshot.
Yeah.
And it's difficult to pull out, what's just, narrative, like in box 23, or
right.
even what's in, the core IPC section. And the all plan letter that you're referring to is the 1410, and I think you had it on your list there.
Yeah.
And I thought I saw that, and it does give us a list of what our requirements are and what we need to be able to pull out. And so what we've just started to do at HealthNet is we created, and I mentioned it earlier, a care coordination tool where it will allow us to pull out that information that we're looking for. But what I'm noticing is that there's certain duplication of information, but again, because we receive it as a snapshot, the IPC, we're looking at this other tool. But we also don't want that to be a duplication of work. We already said that on the IPC. Yeah. We did this long 3-day assessment and, and had to come up with that. So, yeah, that's kind of where we're at with it.
Right.
It's a little bit of a moving target. Right?
Yeah, a lot of questions, not very many answers at this point. Okay, so let's go to some of the things that are coming in from the webinar participants.
Just wanted Kay Hudson had commented a little bit earlier that she believes that the treatment plan should have the person in there. Box 23 is just saying the same things over again. And
Thanks, Kay.
Kathy Osborne had her hand raised a little bit ago, but not any longer. So I don't know if Kathy, if you still wanted to make a comment.
Well, yeah, at the time I wanted to agree that for the plans, we would like to see more sort of written information. The IPC as it is now isn't very informative, and even little things like the diagnosis section if it could highlight out what the new diagnoses are so that we're not having to sort of cross-reference back to the original IPC, would be very helpful. Because usually the centers write out the changes in box 23, but it gets sometimes very long. If the changes were written out sort of in each individual field, it would be very helpful to us.
Okay, so Kathy, just so I'm clear about this, because I'm making some notes, you're talking about specifically about change diagnoses, new diagnoses from one time period to the next, but also you're looking at any kinds of changes in conditions if we can find a way to capture when something is newly identified from a previous IPC?
Yeah, because like even like the members' living arrangements, that changes, but we don't always understand that it's changed or even how it's changed, and that's pretty important. I mean, if member was living at home alone, but now a care provider is living there, or the care provider has to work now, so she's not available as much, that's really helpful information for us.
Okay, so were there other things here? Okay, Ken's next, and then Amanda.
Most of this information is already existing on a progress reports, flow sheets.
Yes.
So if an internal person, like a doctor or a nurse, doesn't go to those and get the information, is not whatever documentation you provide, they will not read. So it's part of the system that you have to have all these people looking at this information that's recently added to the system. And it exists every day. Every day, if something happens to participants, it's written in the flow sheet that today something happened to a participant or in the family or whatever. Summarizing after 6 months the whole thing again is not going to help anybody.
Right. So are we going to just to throw it out there to be provocative, and I'll get to you, Amanda, are we like maybe going to a concept of an initial TAR that looks one way and a re-auth TAR that looks another? Or IPC? So the initial IPC captures all of the sort of status information, and then there's, from that point forward, we capture only changes? Just a thought. You don't have to answer it, just a thought. Amanda?
So just when you were talking, Ken, and I was thinking about the turbo TARs and the CAD cares and all that. So we're like you said, we're documenting every, y'all are documenting all the time, and it's in the chart. What if this gets into the computer piece of it, what if there was a way to flag the information that you documented that would automatically tuck it into, say, box 23? And then at the end of 6 months, you could go through it and kind of erase what you didn't, delete what you didn't want, or kind of clarify. But then it would be there for the managed care companies to see these changes, because I think the changes is huge.
Yeah.
As a managed care company, as anybody to see, even going in as an LCSW and doing a review, it's a lot easier if I can see a progression, because I'm not in there every day, to see the progression of somebody's mental health or even their living condition, anything social work oriented or even health related, to see a progression. And if I could go to one page, and maybe it's automatically put there through we can ask our
Sure. And I think just to tell you about one of the challenges we've always had, and it goes to this checkbox versus narrative box discussion, is that once upon a time we had a lot more narrative in the IPC, and then we went to more of a checkbox format, and so there's a tension between not wanting to have open boxes where we just have people writing in anything because we have more uniformity with checkboxes, but then if we have too many checkboxes, we just have a lot of checkboxes. Okay, so Dawn, did you raise your hand?
Yeah, I did. The question keeps coming to my mind, why?
Yeah.
So I'm really curious, for the folks that are literally looking at the IPCs, and the Kathy on the call, she seems to find that the IPC reviewers like that narrative. They want to see those changes and all. And I'm asking myself, why? What are they doing with that information? And I think it's a good question to answer. If they are questioning, is CBAS enough? Then let's ask the CBAS providers, is CBAS enough? Is there more needed? I need the health plan to know this. Is it justifying CBAS services? is that really where we should do we have to justify ourselves
Is
if
it
we made it
days
through
of
this
the
process?
week, days of the
Yeah.
week, for example, if you're asking for more days of the week.
Yeah, so I mean, I'm getting back to,
Right.
if we're going towards a narrative in some way, we need to really understand why that's important.
Or maybe it's care coordination purposes.
And it's
Maybe.
and value. I think, to me, it's if under the court, I'm sorry, I jumped in.
It's okay.
Under the care coordination piece, you know, it makes us more valuable, I think, to managed care to be providing them with information, as opposed to having them, you know, because of course, if they have to go to the participant, and then we're at the participant too, and maybe in-home supportive services is at the participant, that's all kinds of information. If they can rely on the adult day to provide them with the information, doesn't that make us more, I mean, potentially it makes us more valuable.
I would question how that gets used. I mean, I really would question that. And I'm curious about this assessment of assessments, because I think that is, there's something there.
Can we come back to that, because Kathy actually raised her hand. I think Kathy has something to say about the why piece, and then we'll go to Chris in the room, and then we'll come to that one. Okay, Kathy.
So the last speaker took the words right out of my mouth. It is for care coordination that we need this information. We're now being tasked with reviewing all of our own assessments. So like my CBAS team reviews the CBAS assessments, the MSSP assessments, and the IHSS assessments for a given member so that we can ensure that the member's needs are being met as a whole. And so we're also looking at, is there something that CBAS isn't able to provide? Can another service provide it? And then we're having to contact members and make referrals for that. So that the care coordination piece is exactly why we're sort of wanting more information from the CBAS centers. We recognize the centers as the experts on our members, so we need really current, up-to-date information.
Great, thanks, Kathy. Okay, who did I say was next? Chris.
Yeah, so we already do our IPCs in 2 different ways, you know, in a sense, because we realized that we could just stop filling out the summary and everything worked the same way, and we wasted no time on it. So unfortunately, it felt like we were doing a lot of extra effort to create this beautiful summary of what the whole person's story was and what you couldn't see, what was happening like underneath the layers, like what's happening in their home and their family and their loss and all these things. And it turned out that it didn't really matter as far as, you know, we weren't getting any feedback. There was no feedback, and we just stopped doing it, and nothing happened. But when we switched, we were one of the first centers to switch to managed care. We started realizing that they needed information before they did a face-to-face, and that they needed to make sure that we were, it behooved us to basically pre-screen people. So we went and we took the step to meet with the individual, make sure they were meeting our criteria, and we created a summary which we sent to managed care, and then they did a face-to-face, and everything worked out perfectly. And so that's what we do now in our initials, is we give them a summary of the whole picture before we ever create a, an IPC and do the 3-day assessment. And it kind of streamlined our relationship, and it made it easier for them, and it represented the participant better.
So just a clarifying question, then we'll go to Lydia.
Yeah.
It can't possibly be the whole picture, right? Because you haven't done your 3-day assessment. But
it's the information we have.
Okay, the information you have.
And it's not always right.
Right.
But it's what we have.
Right. So it's the starting point.
Yeah.
Lydia?
So at the plan level, so Kathy, Selena, Gretchen, James, are you actually adding, typing in as your care coordinator or somebody at the plan, keeping care notes, case notes in a particular, is that only for CalMedi Connect people, or is that for anyone that would include a CBAS person that's not in CalMedi?
It would include both. So according to our plan letter here at 1410, right, we do need to collect all the care plan information, assess the assessments, send that off to our case managers and care coordinators so that they can review those in more detail and
So someone is going to be typing that into a computer, not handwriting notes and passing it to Selena, right?
Well, we're going to try to do it by pulling the data. We're going to use a system, an OCR system, to try to pull the data out into a format that we can use as a summary. But I'm hearing that the plans are doing it differently.
So we're collecting the same
You're
information
collecting it,
and reviewing that.
Is this a one-time activity, or are you supposed to do it all
This
the
is
time?
ongoing.
So I guess I'm thinking about the conversation we're just having, and if the it seems like there's several different needs going on here that we're trying to address with this very simple little IPC form. And it seems like we're mixing those things up because the information plans need about a change in condition seems to me it's a phone call where the plan, if they have a care coordinator, if they don't, is going to somehow do something with that information, or a note. Because some plans are approving 12-month TARS IPCs now.
Right.
That is not going to give the plan the information they need about changes in condition or status.
At the frequency they need.
Exactly. So I think we're kind of starting to mix up the different needs, and it's a good conversation, don't get me wrong, but to kind of focus us back on what is appropriate for the IPC, I think we just need to keep a list of things that are sort of outside of that realm, and then what's really in this realm for this task.
And so
Does that
it
make sense?
Hang on, we got a bunch of people queued up here.
Yeah.
But so just to finish this thought, and I still want to come back to assessment of the assessment, so help me. But it's still, it seems like it's relevant that they would need more information on the changes in condition sort of between TAR periods, but still a relevant discussion about the TAR, the authorization TAR needs to have some kind of changes reflected. Okay, so let's go to, I think Randy is on the line. Okay.
Hello, this is Randy.
Okay, hang on just a second. Okay. So Randy, we just muted you, but I think what you need to do is turn your microphone off on your computer, and then we'll try you again, but we're getting a lot of feedback, so if we can't make it work, we're going to have you type things in. So let's turn off the microphone, and we'll try you on the phone. Okay, so Randy, we'll try to come back to you. So if you're talking on the phone and you've got your computer microphone on, you need to mute the microphone on your computer.
And make sure she's on the telephone.
And make sure that you're on the telephone. Okay, so we'll come back to you in a minute. Is there somebody else online that needs to talk?
No.
Any written comments from anybody?
Nothing new.
Okay.
So I have just
Okay.
a response to. So that's also the purpose of that care coordination tool that we created and put on our portal, is so the centers can go as there are changes and updates and put it in. But so the feedback we're hearing initially is, well, I already put that on the IPC.
Okay. So it's a
again,
training
that's
thing
where
about what it is that's what you guys are intending with that. And you did share that at the CADS meeting on Wednesday session. I remember that. Yeah, the portal. Yeah. So that's a training issue, getting everybody on board with what you guys want them to do. Right.
And that form is more of a check off and update. You know, here you can refer here.
So Gretchen, we'll close out with that, and then we'll come back. Okay.
Well, I was going to go with Lydia that just to save our sanity, maybe we need to separate out the issues that we were dealing with here. But I don't know if Kathy would be willing. Maybe the health plan folks, we're going to be getting some information about where are the issues related to the overlaps in the different assessment tools. Maybe we could form a little subcommittee and like among ourselves try to figure out what is happening. What kind of information would be helpful in this process that we're trying to put together?
That'd be great.
I think that's a great.
Maybe we can bring that back, and then you guys want to have it.
Yeah, because I think we want to respond to that.
But we don't quite know what we need.
Yeah. And I will tell you, from a CMS point of view, we think we're doing a fantastic job. Right?
Yeah.
So we don't really see what you guys need to do. We're doing it, right? We're connecting with the physician. We're bringing in IHSS. We're connecting them with, legal. We're taking care of everything.
Right.
We think. So if the plans don't see it that way, and now they have these other requirements, I think we need to really embrace the collaborations that we can do with the health plans and not feel like we have to do everything ourselves and really take advantage. And it seems like to the plan's point of view, and just from what I'm hearing, you want that. You have staff that are there to partner with us. And so we need to figure out what that communication is going to look like.
We know
and it might not be the IPC. It might be a whole different mechanism.
Okay, and we'll work on Gretchen's idea that we have a subgroup that fleshes out what the plans need and what needs to be in the IPC. So we'll do some more work on that, I promise. We got some stuff online.
Okay, Randy was able to type in. As a nurse reviewer, we need the information for medical necessity in determining the number of days a member attends. We also need to see changes in condition when the centers request increases in services. We also look for gaps in care that needs to be addressed and submit referrals for services that aren't covered.
Yeah, great. Thank you, Randy. I'm glad we got your feedback.
Okay, and Lynn has.
And Lynn.
Lynn suggests it may be helpful to look at Special Terms and Conditions 98C1. Sorry, it just jumped on me.
I know where she's going because I can read her mind.
So to address info that the plans need.
Yeah. So let's go ahead and try and pull that up if you would start. Oh, it's me. So I'm working on it. Okay. So I'll just work on this because what Lynn is reminding us of is that we have things that are spelled out in our waiver about what is what the coordination is required to look like for this program, what the plans are required to do, what the providers are required to do, and maybe somebody give me some cues. Okay, here we go. So it's so I'll just try to pull up the waiver document really quickly. I can't see this very well. That's Special Terms and Conditions, and we'll just pull up 98C, which is where we have all the coordination issues spelled out. Is there anybody else while I'm pulling this up who wanted to finish a thought? Go ahead, Selena.
Well, as you're pulling that up, 98C1 and the 1410 APL requirements really go hand in hand.
Yeah.
So you're looking at one.
Yeah.
Is the 1410 of the list on the internet somewhere?
It's on the CDA website.
Yeah, it's linked to, and it's also on the DHCS website. So I'll take a tour of that with you guys next. So let me just this isn't very big, so let me see, maybe somebody can help me with getting a bigger magnifying glass right there.
Oh, I'm sorry, that's a find. Down below, maybe the, that'll pop up.
Okay, so let's go plus. I'll try to make it bigger. Okay, so this is the requirement in the waiver that specifies the responsibilities of the managed care plans for the CVAS benefit. And then if you go down to C1, thank you, Lynn, for the reference. Coordination with CVAS providers, coordinate member care with CVAS, ensure the following. CVAS IPCs are consistent with members' overall care plan goals, so that's the link between the hierarchy of the plans, the IPCs versus the ICPs, right? And exchange of participant discharge plan information and reports of incidents that threaten welfare. So this is a conversation Gretchen and I were having earlier that we know we have some challenges with getting the reporting right still. So we got really basic levels of communication that need to be in place that aren't happening, that we've got some education to do around. This is what Lydia was mentioning, clear communication pathways to appropriate plan personnel, having responsibility for member eligibility determinations, authorization, care planning, including identification of care lead coordinators for members who have a care team and utilization management, and then changes in condition also, and then any changes in policies and procedures, et cetera. So these things are all spelled out in the waiver requirements, and they do link in, as Selena mentions, with our all plan line.
They do, but the number actually that I think even better aligns is 96C.
Okay, so 96C is where we, again, still in our waiver requirements, and I'm going to, how do I do that again? I'm going to bring it down just a little bit. 96C is where we have our IPC requirements, our person-centered planning, and where were you looking specifically, Selena, that you want me to highlight?
The whole 96C, the IPC requirements.
Okay, so this is the IPC written. A lot of this is repeat for all of us that we're aware of, that it has to be appropriate for the individual's assessed needs as determined by the center, and the IPC is submitted with supporting documentation for level of service. So they to make the determination about how many days per week, et cetera. This is where all the person-centered planning material got inserted in the waiver in last December by CMS, where we have to put a whole bunch of new stuff together to make sure that we're meeting person-centered planning requirements, and it's also elaborated on here. And then this is all the stuff that's straight out of the regs about what needs to be in the IPC. So there's certain things we can't tinker with in the IPC, right? That have to do with what's in the regulations. Okay, so that was a quick review of that. Where are we? We wanted to talk. Did you want to talk about assessing the assessment, or is that part of that subgroup activities?
I think we can pull it out.
So, Dawn, you wanted to hear about that because that's maybe informing what it is that needs to be in the IPC. But I think part of what we were proposing is that we would have a separate sort of work group
But if the plan can pull together to see what we're up to. But if anyone's interested, we'd love to have you involved. So just let us know. Volunteer.
Okay. And also,
understand that
it's true that we're also. It sounds like we're still building. Right?
Yeah,
so you guys are charged with.
We're still building, I think, and Blue Cross sounds like they're a little ahead of us.
That's Kellogg.
Or Kellogg's.
I'm sorry, Kellogg.
Yeah.
Bob Arrow has a comment.
Okay, so Bob has a comment.
Okay.
The person served is the primary customer. Others involved are secondary customers. The IPC is primarily for secondary customers. The person served has little interest in the IPC until they disagree with the services provided and need the IPC for legal purposes or appeals. Very little genuine interest from the person on the IPC. It's clinical speak. People served are much more interested in practical things like staying healthy and having some social interaction and fun at the center. The IPC is the system serving to cover necessary bases and meet governmental requirements. Ask yourself if the narrative about the person will make it any more interesting to them. And I gotta scroll down. Is it worth investment? Will making it more person-centered add value to the person? Maybe some CBAS participants and families need to be on the stakeholder revision process.
Yeah. Bob, thank you. So Bob articulated a number of, I think, points of view that have come out, throughout the process. So I think, just I'll comment, and anybody else who's nodding around the room, I think that, in part what he's articulating is because of the IPC and the way it's designed right now. It's for the secondary users more so than it's not got the person-centered focus, and we're trying to move a little bit more in that direction so that it is of value to the participants. That is part of what we're about here. But absolutely, it's not an unimportant consideration that we write this thing so that we can authorize services and pay for services and have providers knowing what they're doing on a clinical level. So it's great feedback. I think we are trying to move it in that direction, Bob, and it's a good perspective to bring us back around to. Does anybody else want to weigh in on any of that? Okay.
So I think that we can create it to be much more towards the way Bob is looking at it. And I do, yeah, absolutely. And, the narrative of, the participant's going to, in what I propose is that the participant and or their family are going to be involved. So they will read the narrative, and that will be a part of it. And they'll understand that they are integral to their own health care, that relaying this information to the managed care company, say, or to the doctor, is important, so that this person becomes a human being to everyone involved. Right. And that's kind of what I see the narrative is creating a human being out of what has been in the past the medical model, not 100%, but toward that edge of medical model, and then kind of moving over towards the person-centered.
Right. So, and that goes to the meatier, subject of the interdisciplinary team approach that I mentioned earlier. So, if we want to merge onto that topic, I think what you're saying, Amanda, and in part what this group is still obviously wrestling with, it is how much of this stuff gets incorporated into our IPC tool versus how much of this stuff, in order to meet the federal requirements and in order to make things more meaningful, as Bob was indicating, to the participant, how much of it goes in the existing IPC or the revised IPC, or how much of it is developed sort of outside of that or as an addendum to it or whatnot that captures that. So I think that's sort of something we're still trying to entertain. Yeah, Lydia.
This is really maybe a useless thought, but it seems like there's some connection again with the quality work group. I think about the people around this table who are providers. It's like the plans can have 100% confidence that these providers are doing what they say they're going to do. They're providing good quality. And you don't have to worry about them. You know what I mean? Now, there's information you guys need to fulfill your duties that, you know, we can talk about some more. But if we can just somehow find that right balance of, you know, what's the minimum we need for this secondary audience that that Bob just talked about, and then everything else that the providers are doing already is or should be or could be improved to be the person-centered approach, right? That's going to be training, and you know, a lot of the centers have already embarked on that journey. So I guess I'm just reflecting on there's a way we can link the quality output from the morning group that we end up with this. I don't know how to do that yet, but
Yeah.
it was just a thought I had as we were talking, because we are trying to meet so many different audiences, and we have such a wide array of providers in terms of understanding quality today, you know.
Yes.
I know you're
Yes,
very
absolutely.
aware of that. So anyhow.
Absolutely. Yeah, Lois.
The other piece related to
Oh, I'm
this
sorry.
that the providers are, I think, almost without exception, stretched pretty thin.
Yes, exactly.
Personnel-wise, staff-wise. And so adding to it makes it more difficult.
Right, right.
So streamline, the more we can streamline.
So I think we're going to go to start brainstorming some ideas around that. So, because I think Diane is right, but we need to maybe start thinking about prototyping a few things and throwing some alternatives out there. Ken, what were your thoughts?
Now, we should not consider the APHCs or CVAS centers the only providers. Plans have many other providers that they get the information from them.
Sure.
So they have more information about the participants than we have. So the information is not less as far as they are concerned. So we should not take all the responsibility that we have to provide everything.
Sure.
They have other providers that they get their information from, the hospitals, doctors, and all the other providers.
Right. I think that everybody would say a true to that first statement, but I hear some cackles from the crowd that I think that there is a perception that we have more in the CVAS centers than the plans have, at least at this point. So does somebody want to comment on that?
You definitely do, but you are right, and that's part of the assessing the assessments. We're gathering all of those assessments from the multiple providers that one person, that one member sees. And, you know, but CVAS does play a huge role because you see them multiple times a week, whereas other providers do not. But to your point, we are gathering those assessments as well and taking a look at them as a whole.
And I think to the underlying point for you, minute, that I think we are trying to pay as much attention as we can to not being overly burdensome by creating some new processes for CVAS providers. You know, that's very much in the forefront.
Yeah, and my thoughts on that was, if I say to you, tell me about your participant, Jane Smith, you tell me about Jane Smith, and then Jane Smith is one of your clients, one of your case managers. Who's going to know more about Jane Smith? You are. We know we know the participants, right? I mean, we know them, and that's I think what that little conversation was. Is they know a lot medically, they know a lot clinically potentially, but we know them as humans.
On a day-to-day basis.
Yeah.
Okay.
So I think as we look at the IPC, I keep going back to the change. So what's the change between the first IPC, or maybe the initial IPC, and the reassessment? You know, we really do need to think about that, because I think that's important not only for the managed care providers, but I think sometimes for physicians too. So if there's a way in the IPC itself, I mean, maybe it is the old little checkbox that this is a change in condition.
Yeah, sure.
And we just identify it that way. So when the managed care is looking at it, you check that little box, this is a change, and maybe it steps out, or maybe it's bold, or maybe something that identifies in the IPC that this is new. Yeah, this is different from the last one.
Yeah. Definitely hearing that request.
Because I think that would be good for us too as providers.
Yes.
Sometimes, you know, to remind us, you know, where we've come from with this client.
And we've been, because we've needed to have these conversations, more foundational conversations, I haven't made us get back on the work tool. This is probably more valuable. But part of what we'll see when we get into the work tool is that one of the things we're required to do is to add on some progress. So we did. We used to have that, and we got rid of it, and then we went back to it. It wasn't all my fault. You guys did it too. So yeah, once upon a time, somebody decided that wasn't useful anymore, and it was probably because it became sort of checkboxy. So again, it might have been how it was written before, but now, maybe that's the idea on the table, is that we look at having some kind of an abbreviated re-auth IPC where we are identifying somehow the changes in condition. Yeah, Ken?
Yeah, we do that for the progress report
Yes.
every month.
Progress,
Yes.
progress.
So you already do it, so how could you do, we translate something like that maybe to the IPC so that it doesn't cause any duplicated effort, but that it your progress reports feed your IPCs. It's a possibility. Dawn, did you have something? Okay, thought you did. Okay.
Part of that.
Yeah.
Progress.
Right. Okay, so let's do this just for the sake of wrapping up this part of the discussion. I think it would be a helpful exercise, and you guys tell me, because I think it's also going to kick off some of the larger discussions that we have to have. If we get on the work tool, if you just open up the Word document, I think it is. Oh, it's in front of me. Why am I asking you to do it? Yeah. Okay. Here, let me see if I can do it. I have a hard time doing two things at once. Okay, so if we look at just this, remembering again that our work tool, we don't have to, go through the exercise today of filling all this out. But if we just look at how this is set up, and then maybe some of us will get busy doing this in between meetings here. The CVAS waiver requirement. It specifies, and this is under that 90, I think it's under 96C where you were talking about, Selena. We have to identify each participant's preferences, choices, abilities, and the strategies to address those preferences, choices, and abilities. And that is like the big enchilada right there, all in requirement number 1 in the waiver. So I guess sort of try this whole thing exercise on. Do you guys think that we currently have an IPC that identifies the participants' preferences, choices, and abilities, and strategies to address those preferences, choices, and abilities? Do we have an IPC that does that?
No.
Okay.
Abilities to a certain extent.
So to a certain extent, we have strategies for meeting certain things, and that's called the interventions, and yeah, go ahead, Dawn.
One clarification, and it's a language. How will the plan identify? Is that the actual language?
Yeah.
The plan will identify?
Yeah. So
meeting the IPC?
Yeah. So I could pull it back up if I could get there quickly.
Because the distinction I'm making in my head, how will the planning identify each enrollee's preferences, choices, and abilities?
Yeah. So
when we were going through 96.
Yeah. Let me just pull it up as quickly as I can here. I'm looking for it right here. It's not that. It's not that. Oh no, it's in the quality. It's in the quality tool here. If you see STC something, tell me where it is. There it is. Waiver requirements. Okay, so 96C. Down at the bottom, out of order. Okay, so this is exactly what it says. The person-centered planning process will, with further development under the stakeholder process, that's what we did, and this is what this work group is about. This is the extension of the stakeholder process that we just think we're engaged in. And part of our HCB plan, we're going to comply with requirements under here. So all of those requirements we have to meet in the federal rules, okay? And then this is specifically what our waiver says. That the person-centered planning process will comply with these requirements, including specifying how the IPC itself will identify each enrollee's preferences, choices, and abilities and strategies to address those. And then the next one is how the IPC will allow the enrollee to participate fully in the treatment. Okay, so that goes to sort of process stuff done. How the IPC will ensure that the enrollee has informed choice. That's kind of going back to that participation agreement discussion. And then how the IPC process will be collaborative. That's collaborative with the participant, et cetera, recurring and involve ongoing commitment to the enrollee. So there's a bunch of process stuff that's identified here, but this is pretty much the IPC is
Because if we're concrete, just to do part B, excuse me, if we're concrete, then how, just looking at number 3 there, that we're just saying how the IPC will ensure the enrollee has informed choices about treatment and service decisions. Is that a narrative, or is that a checkbox, or is it really, is the IPC a reflection of, the option of choices and about treatment? I don't know if I'm making myself very clear, but I feel like in order to avoid this long narrative IPC that's going to address this, the distinction should be made right at the very beginning of this process, because for me, I'll get tripped on it again and again and again. Because if the person-centered planning process is a good process,
Right.
all these things will be incorporated. Does every single reference to a preference, a choice, and abilities have to spell out with those words on the IPC, participant's preference to address their hypertension is,
I get you.
I think we're leading down a very non-professional path.
Yeah.
Not to disregard the person.
Right, and we'll come to you, Liz. And this is something our chief counsel always reminds me of when I bring some issue to her office, and she always reminds me that when things are not explicitly stated or explicitly clear, that we go to the reasonable person standard. What would a reasonable person? And we go to common definitions of terms. So if there's nothing else that explicitly tells us what the definition of the term is, we go to the commonly understood definitions, and we go to the reasonable person standard. So I guess I'd say to some degree where there's some ambiguity about these things, we're going to come up with what we think is the reasonable sort of standard for applying this, and then we'll ask our lawyers. So that's my take on that. Liz.
So I'm just trying to make sure that as we're filling out the IPC that we're actually making sure that it's the participant's preference and choice and ability. Is a way to capture that is at the end in that signature page, that there's a format where somebody on staff has actually sat down with the participant and the participant's family member and gone through the intervention, that these are their choices, these are their preferences, and that they are part of signing their own actual care plan. That might be a way to capture that they take ownership in the care that we're going to be providing for them, and that they're part of the choice.
To the extent possible, and that is part sort of the participation agreement. So, okay, so.
Were you in the room?
Go ahead.
And I think that depending on the way that we decide we're going to run the actual plan of care, it will, and how that's written, that can easily be integrated into it. That some of these items, instead of being a checkbox, yes, we provided choices, yes, we did this, yes, we did this, this will all be reflected in the actual care planning process, potentially.
Yes.
So, and that kind of goes back to some of the things that Bob was saying about and Liz, I mean, again, remembering that our current regulations say you have to review the participant services, the days they're going to be receiving services, and they have to agree to them and give their consent on the participation agreement. So, to the extent most people understand that, I don't know. But if you were actually reviewing today's IPC with somebody and showing it to them, what Bob was saying is that it wouldn't be very meaningful to them. So I think that what we're saying is what might make that more meaningful in the participants' language of what their preferences, choices, abilities are, not to take it to the ridiculous extreme that I think you're afraid of, Don, which is that every single thing has to be worded in those terms. I don't know how that would be possible and why we would interpret it like that. But I think that it's very clear that CMS wants us to focus our attention on making sure that the participants' preferences, choices, are reflected.
Bob has a comment.
Bob.
Isn't some of that, though, process, isn't some of that the center has embraced and incorporated person-centered care, like what Beth and Lynn teach us?
Yes, yeah.
So not all of that's necessarily going to be, I don't know that you'd write on the IPC that they're choosing X, Y, and Z activity group to participate in, because that's a daily choice they're making.
Right.
So it's really a different way of...
It's really a good point, Lydia, and I think that's where we're trying to find where we draw the line here. And that's exactly what we're trying to do.
Exactly.
So Bob has got some more comments.
Document that the person served and their families/representatives have made an educated choice and preference. If their choice is unreasonable, then decide whether you are able to serve them with a clear conscience. Balance choice with liability.
Okay. Good thoughts?
And would that have to be readdressed in every care plan then? Because remember, our participation agreement, we don't necessarily have them re-sign that every 6 months when we do a care plan.
Right, and I think that that's a problem. So I think that's one of the problems that we face with our, how the IPC process will be collaborative, recurring, and involve ongoing commitment to the enrollee. And right now we have requirements that say that they sign off at the time of admission.
So
One time.
I mean, it's not, you know, to go to, I mean, I can say, when we get actually to the care planning piece, you know, I think it's that, yeah, of course the participant would sign their care plan. They're part of the team. They are a member of the team. There isn't, so of course they would sign. I mean, to me, if we're looking at person-centered care, they're a member of the team. Why would they not sign?
Or they're
care, well, what?
Yeah.
Diane Cooper were still on the phone, she would be
Yeah, Diane has an issue with that.
contrary to that
Right.
because for a variety of reasons that she can articulate better than I can, but I don't think we should start with that.
Yeah, it's not a foregone conclusion, I guess, is the thing that that's what I've found in my conversations with people. And again, I think it comes back somewhat to this issue of, do we have the preference, choices, and abilities articulated in the terms that the participant would be able to sign off on in the care plan, or do we have it somewhere?
I apologize. When I say participants, I mean participant and or their family member representative.
Sure.
I'm not specifically,
Yeah.
you know, I would never say a participant who's.
I think we're meaning those things interchangeably, but I think that that's still sort of the issue of the dispute, because I was you know, initially saying the same thing about having participants sign the care plan. But the more we go into this discussion about having the care plan, maybe having some things that are outside of the IPC is what I'm talking about, signing the IPC box 24 versus signing a enhanced participation agreement that has a restatement of the participants' preferences, choices, abilities, and
I'd love to hear the argument.
Yeah, really, yeah. Okay, Chris.
We have plenty of people that probably couldn't sign for themselves, nor have a caregiver or family member who could sign for them, or understand clearly the message that we're trying to relay, or even agree to any future. Because,
And you know what I mean?
and
That, well, yeah,
so
absolutely.
that's-
So that, I mean, I don't think there should be a hard, fast, you know,
Mhm.
I agree with you. It should be hard and fast. And I think if we're looking at, you know, person-centered care, the participant is a member of the team in as much as the participant can be involved. So you can't say, you know, participant with huge cognitive impairments didn't sign the IPC, you're majorly dinged. That shouldn't be a cause. But if that thing, but if we're following along with what we've been asked to do, and we're doing person-centered care, the participant has to be involved in their own care plan. And my feeling, and if I haven't heard any arguments against it, except there are. So you know, I'd love to hear them because I don't know.
Sure. Does anybody want to jump in on that? I don't know if it's arguments. I think that this is
discussion.
sort of,
I should
just framing out
operationalize it.
Yeah.
Right. Yes, I think that's it. I think it depends on what, I mean, the IPC, the way it exists now, is so confusing, so medical speak, so unintelligible.
Right.
I mean, it took me months before I got what it was about when I was there, let alone a participant with a little bit of dementia. But I think I think the thing is that obviously we need to have and want to have participants involved with that. But you know, what piece of paper are we asking them to look at and sign? What are we asking them to sign on to? We certainly couldn't ask them to sign on to the IPC like this.
The care plan.
No.
Yeah.
My thought is the care plan. But why not allow them to see the whole IPC if they?
Oh, I don't have any problem with that either. But I'm just saying, I think I have very few participants at my center, very few, who would be able to meaningfully sign off or, you know, on an IPC the way it exists.
Are there family members that could?
It's not
Some of
always
them yes and
possible.
some of them no.
It's not always
Yeah.
possible
Right.
to have family.
You've got participants that have no literacy in their native language, let alone English. These are always written in English. I mean, there's just a lot of barriers to, you know, barriers to receiving medical services if you're not literate in your language, you know, read or speak English, on and on and on. You guys all know all that. So I think it's just trying to think about how to operationalize this in a way that's meaningful. It's not just an exercise and checking off another box or getting a signature. It's really, to me, person-centered care is more about the process, how the center is embracing the philosophy and implementing it. So,
And so I'm going to always come at the,
Yeah.
because I'm from a clinical standpoint,
Yeah.
and I'm always going to come, and care planning is, my thing. So I'm always going to come at it and, how is what we're documenting, how is what we're writing, how we're involving the participant reflected in our documentation? Because our language and, the inclusion that we do with our participants, which is about person-centered care, and how are we reflecting that? How is it being reflected? If we say we're providing person-centered care and we're working as a team and the participant and their family is a member of our team, and yet they're not involved in their own care plan, nor are their family, it's going to be a change in the way that we provide services. Person-centered care, going from a medical model to a person-centered care model, is a big change. There's no doubt. And we know that it's a process, too. We know that it's not, this is, it's hard and fast. And I think that's why, the clinical piece is so important to me. And the center and how we treat our participants in the programming is important, and the space that they're in is important, as well as the clinical piece, which is what the care plan is reflecting on.
right, which I'm just, to kind of be devil's advocate, the clinical piece is the part that the participant is least interested in.
Yes,
Right.
yes.
That's what you need to do as providers to comply with Medicaid law and rules and managed care's requirements for being a Medi-Cal, care provider. So I think we've just got an inherent kind of conflict.
Well,
You know what I mean? The
No, and I
participant
would
is,
suggest that in the past, the clinical piece has not been important to the participant. Because if we go all the way into the medical model, the medical model basically tells patients and that they're not important. It's the hierarchical. This is what you're going to do, and this is how we're going to treat you. And they've been conditioned, as we all have, to be a part of that model. And person-centered care is the opposite of that model. It is, Mrs. Smith, how would you want to go, you guys that are how many went to the training that Credula and I provided, how many, do you want, you want to stay living in your home. How can we figure out how you can stay living in your home independently? That's what you want, Mrs. Smith. So I would suggest that in the past, the care plan has had nothing to do with the participant because we've been looking, from a medical model. But the care plan is it's still important to the participant when we're looking at it from the person-centered model.
Dawn?
I just think that the front-end piece is the most critical piece, and as we roll out a new IPC, we want to roll out a whole person-centered care planning process. The outcome will be an IPC that makes sense, but I don't think we need to capture everything that was captured when the social worker asked those very questions and when the physical therapist asked those very questions, and it's all there in the chart of what this person's ultimate goals are, whether it's to walk without a walker or live alone in an apartment, which is completely an unlikely direction to go given the person's situation. That's all the process, and I want us to be really aware of how we're going to translate the planning process into an industry-wide adoption of a process. Think about that almost more than did we capture all that on the IPC? Does it talk about the fact, well, they'd like to live in an apartment, but that's not really, so our first goal is just to convince them that, or to experiment, I don't know, but my point being that I just don't want us to get into this place where this IPC, this piece of document at the end of the day, is is the driving force, and that it all happened in the front end, and that we as providers need to really make sure that we are united as the 200 and some centers that exist in the state, and have clear guidelines on how, because if we don't do that part right, the IPCs are going to be all over the map, and we've really accomplished nothing other than to teach people which boxes and how to, what sentences to use.
Right. Great. Thank you.
Yeah. Lynn has comments. There is a DHHS guidance document posted on CDA's website, guidance to HHS agencies for implementing principles of Section 2402A of the Affordable Care Act standards for person-centered planning. describing how to implement the person-centered planning process and develop the care plan that may help clarify some of the questions raised. We will post this document on the Workgroup Documents webpage.
I think I actually have it in the folder, so let me just take it. We're kind of getting close to the end of our time here. I think that, oh no, I'm back in the quality strategy here. Let me just see if I have it just to take a quick peek at it. I think this is the document that Lynn is referring to. Lynn, give us a thumbs up if this is what you're referring to, and
Yes.
this is okay. So this is what Lynn's referring to: guidance to Health and Human Service agencies for implementing principles of the Affordable Care Act. So, okay. So I'd like to hear what you guys are having to say here, but it's okay. We're coming to the end of this whole process, but we have this document. We'll put it up. So there's some guidance out there, is what Lynn is saying. So maybe we don't have to like completely reinvent this, but obviously we have. These are the sort of foundational issues that we need to work through before we can start sort of prototyping a bunch of things. But I will add this though on that prototype thing, because we talked about this earlier in the day. Diane had suggested that we do something where we start playing with some of the fields we know we want to scrunch down that are in like section 1, 2, and 3 of the care plan itself is what we're talking about now. What's in boxes 21 and 22, and then to some degree we're talking about section 24, which is the sign-off. Right? So we have to think about the many pieces of this IPC. So we're kind of debating what goes into the IPC itself and how well we can articulate the participants' preferences, choices, et cetera, there versus somewhere else. So I think we just need to be clear that this is one piece of the IPC as it's currently done. So there's some process stuff here that we'll post this on the website, and I think maybe what we'll try to do is maybe digest for you guys some of the key points that that we have gotten in guidance, and maybe send those out to you as a work group as a follow-up item, so we can sort of think about what the guidance has come, the guidance from on high. Was there anything that you guys wanted to share over there that would contribute to the discussion?
I was just saying, like, some of my participants, it's not that they don't care. They let you know when they're not happy about it.
Right, oh yeah.
They really, it's too much. It would be too much. They would be like, of course you're going to feed me lunch. You know, if I don't like lunch, I'm not going to eat it. I'll ask for something else.
Right.
So we can't make it so overwhelming that it's not fun or engaging for them to come to the program. If they think it's going to be this huge medical thing always following them around,
sure,
they're probably not going to want to participate.
Sure, and I would sort of, as a sort of somewhat counterpoint to what we do right now that I think doesn't work very well, in our current participation agreements that I read, where we basically have the participants saying, yes, I've been informed of what my services are, yes, I know what days I'm supposed to attend, and then they sign off at the bottom, or if they can't sign, they put an X, or their caregiver signs. They're useless. You know, it's like, it doesn't say, it just says, yes, I've been informed of it, but it doesn't give anything else. I personally think that we need to invest in thinking about the participation agreement, enhancing that, where it says, I have had my care plan explained to me. Not only that, I've participated in building it, and here are what my primary objectives are in coming to the center, maybe even having something stated about, you know, what it is that they are coming for, and that they sign off there, and that would go a long way to clarifying what it is all about for them. I'm not saying that's the end of the discussion, but that's one of the pieces that I think that we need to work on for retooling, because it's already in place. It's just we need to fix it a little bit better, and we validate that you guys are having not the conversation about every single meal, but that you guys are really working with at meeting their needs. There's nothing really that does that now. Okay, you guys, I think we pretty much beat this horse to death. So we'll put something together for you on this guidance document, so that we're clear there. So then coming back to this tool. So I guess as sort of next steps go, we have on our agenda, we were supposed to be talking a little bit about some of the overlapping issues with quality group, so we make sure again that we're exchanging information. I think that that we kind of things like that have come out, and we'll identify those in our action items and whatnot. What I would like to just do, because I don't want to let anybody get away before we make a few more commitments, and so I heard two major action items for today. One was that we were going to have a subgroup where we're going to sort of flesh out some of the managed care plan requirements, the new stuff that you're being required to do with assessing the assessments, and there was a second one. well, there's definitely the care coordination. Oh, the exchange of information that's required in the waiver and that's required in the care coordination EPL, so that we have a better sense of what the plans need from the providers and what of those things are actually things we want to consider building into the IPC. So that'll help us get a little clearer going forward. So we have that one sort of work group that we've talked about here. And then
Nathan?
Hello?
Is this Nathan?
No, I think you're on the wrong line.
Oh, I'm sorry. Hold on, please.
So we have that. we have that. No Nathan here. So we have that work group, and then I think we talked about having some in between work group activities around working through this tool and starting to identify some things within another sort of smaller group. So to try to get some commitments about that, Gretchen stepped out of the room conveniently, so James, we'll bring that around to you. So as far as a work group for to sort of flesh out this managed care plan needs thing, what do you guys, what are your thoughts?
We're ready for it.
You ready to do it? Okay. Okay. So
we're ready for help.
if we had you know, you who are in the room and either of our other plans, we can put out a note maybe to, you know, the four of you, CalOptima, Anthem, HealthNet, and LA Care, and just ask for your participation. Do we want to have a point person on the sort of provider side, or I mean, I could certainly, we would be at CDA, you know, willing to participate. But is there a provider who wants to step up, or Lydia, or Ken? I see you raising your hand. Okay, Ken's volunteered.
Denise, I have a question. Are you going to just send it to those managed care providers or all the managed care providers?
Yeah,
I mean, staying with them because they're the main ones. I mean, I'm not sure.
Yeah, I think that what we got these guys here as volunteers, and we put out the invitation to everybody, and so these are our volunteers. So I think, you know, frankly, I think that there are some issues which rightly you should be concerned with because you're not in a CCI county. But I think that we can sort of look at what's the CCI county requirements, and these are the folks to do it, and then we'll look at adding on what's, you know, what are the other directives to the plans, unless you guys already have a sense of that. Well, you have HealthNet has non-CCI counties. Yeah. Okay, good. And so does Anthem. Yeah. Okay.
Good.
End of the day. So I think we can get that all represented, Liz. And so, so Ken, you're willing to participate? I think what we'll do probably is we'll just send around a follow-up note after this meeting and just clarify that we're going to have that effort going forward, and then we'll try to get something together before the next meeting. And sorry, I'm off my game with that. Lynn's my usual person for doing all this, and she's at home, texting, you know, sending her notes in by the text here. So, okay, so that's one major action item. Gretchen, we volunteered you while you were out of the room. Great, thank you very much. And,
You're sharing.
Sure. So we'll send a note around about that, clarifying, and then we'll also send a note around about some sort of between work group dates, which our next work group will be in February, and we'll send around a survey monkey for that too. So it'll be either probably the first Wednesday or the second Wednesday in February, and we'll pick the date that most of you guys can do it. Okay, so we'll stay on this every other month thing. And so at that time, we'll also send around a note and ask for participation in trying to work through this work tool and hash out some of those issues. So those were the two main sort of in-between activities that I heard. Anybody else hear anything? I know there are a lot of other action items that we talked about. I don't have them all in front of me.
Oh, Lynn says develop some prototype IPCs.
Yeah, we talked about developing prototype IPCs, and we'll see what we can do on that one. Again, I think that we talked about our software vendors and being very sensitive to what it costs them to do development, and that, but maybe we can actually engage their help in some of these things up front too. So we'll look at that. Were there other items that people have? Next steps? Yeah, Lois.
It's a little bit concrete, but any way that we could be gathering information electronically from our IPCs would be really good. I mean, it just seems so much. I mean, ours are done through TurboCharge,
Right.
And you know, so the information is there, but it's not. It's there, and would be seems like it would be easily captured electronically. There's so much information there, and that it seems like it would be just useful in knowing about. And I don't know if that's possible at this point, and then some people are still doing it by hand, maybe not. But I just think as we're doing this process, we should at least try to get into this century.
So I think it's great. I love the idea, and I'll just tell you a couple things that are barriers and issues there. First of all, we do use information that comes off the IPC, and we use it a few ways. One, for your participant characteristics reporting as providers that you do to us. If you have a software provider, they pull that from your IPC, much of it. Some of it you have to do manually, but much of it comes directly from your IPC. So when we developed that new PCR that we started, that participant characteristics report a year and a half ago, we worked with the software vendors to make sure that they knew which boxes correlated which items on the report, and so they could pull directly from there. For everybody else who's not supported by a software provider, they have to do it by hand. You know, offhand, Adam, how many people we have that work with software providers? I can't remember. I know you know. We pulled them.
Close to 2/3 of our.
Yeah. Okay, so 2/3 of our folks that work with software providers, so but everybody else is sort of doing it manually. So, so certainly the more we go to reporting requirements that, like the new participant characteristics report, the more people get software vendors because it makes it easier for them to do the reporting. So, and then it makes it easier for us to change things too, like Diane had mentioned at the top of the meeting. So, so that's one issue. So we can pull things from there through your software vendors. Through the managed care plans, they don't have the IPCs electronically. It's not happening.
But it would be something that I just think that there's so much information there that if we could just get it all done electronically, that would make such a big difference. It would be really at the 6 monthly reassessments, whether people have been hospitalized or gone to emergency rooms. I mean, that piece is really important for CBAS and what we do, and kind of overall quality of care. It's a real overlap with quality, but a lot of stuff is overlap.
Yeah, I agree.
So,
I agree.
So anyway, I just wanted to put it out
it's
there.
It's important.
So,
Go ahead, Vinny.
But to Lois's point, I mean, other health facilities report data to OSHPD, for example. That would be a statewide database that already exists. But again, it's all going to take money. It's going to take the governor putting money into a system that's been languishing for many years. So,
but again, I guess I'd say you remember when we first started revising the participant characteristics report. So we first developed that report in like 2002, and then we went with that report until like a year and a half ago. And like 3 years ago, we started the process of revising that. And I'll tell you that when we sent it around to our CDA team, we developed a PCR that was like, it was like we had maybe 60 data fields that we decided we must have, right? We said we must have that, and then we, of course, reached out to Lydia and we said, what do you guys think? And what came back from Lydia polling members and talking to all of you experts, and they said, oh God, don't do it to us, please. So we brought it down in size. We still have a lot of great new data fields. So now we have positive identifiers. So we have SINs. We never had that before. So we can cross data like we talked about earlier. It's great. We have enrollment dates. That's great. We have ADL functions. That's great. But we tried to get a whole bunch more things in there, and it was too big a change. Maybe the climate's right now, and we want to do that. We want to expand it because we're happy to collect it. We're doing it right now. We would just expand it or change some of the fields that we're collecting. But it's not through the managed care plans. They're going to have their own agendas, and they don't have anything electronic yet. We're just getting the portals up and going. That's great, but there's no collection mechanism there. So if we want to do it, we already have a mechanism. We would just revise it. So.
But the more we keep it in mind as we're redoing this, I think would be a good
point taken. I agree. Yeah.
Because the software vendors could write a program to upload.
They're happy to do it today.
Was, you know, available to them, but we don't have it today. Thanks.
Yeah. And the software vendors actually, since our director's still in the room, our software vendors actually, at the time that we revised the participant characteristics report, said, hey, we want to just give it straight to you. Can't we just talk straight to your IT shop? They don't even want to have it come through you because they've already got it, you know. So you guys collect it on your end, and then they spit it out on theirs and feed it directly to us. So they're ready to do that. So, so you know, we all have, you know, challenges.
I wouldn't go there. I wouldn't go there. We spend a lot of time picking the data before we send it to you.
Oh yeah, right. Yeah. But again, I think to Lois's point, that if we have something that's solid on the front end for the IPC and collecting it, but again, I know you guys fix it, so. Okay, so this has been a great conversation. Does anybody else online have anything to say to us? Okay, then I think we're just to the thank you part of the program. So thank you. It's been a really long day, and especially for those of you who participated in both work groups. People came a long way. So appreciate you participating in this. We did our best to make sure that you guys were clear about that there's an end game here, that we're not just going to spin our wheels. We have work products. I hope you guys all went away, feeling clear about that today, that we're going to have products that come out of this. And Laura, yes.
Did you all hear the news at lunchtime?
About the regional center?
Yes, I just got updating 14 people who died.
That's
17
awful.
now, 17. Oh, no, excuse me, 17 injured and 14 have died.
Yeah, just awful.
And they have surrounded the shooters.
Yeah.
Not yet apprehended.
One shooter's
Are they
dead.
saying one shooter?
One shooter's dead.
Oh,
I think they said there were 3 or something.
Yeah.
God, unimaginable. Okay, so
It's an active season.
So back to the thank you. Thank you, Laura, for coming in and seeing what we're doing here and supporting us. Appreciate it. And thank you, managed care plan partners, providers, representatives, advocates. We had so much great participation, and we got a lot of stuff to do in between now and the next time we talk to you. So we'll have our work cut out for us, but we are making progress, and so I hope you guys feel like that and that you're like energized about this and that you'll be back for more in February. Okay? Good enough?
Nice work.
Yes, thank you, everybody. Yay. Yeah. Yes.